5, 4, 3, 2, 1. We are live now.
Good morning, everyone. This is the last webinar of Maharashtra Orthopaedic Association. And this is on one of the most important topic, osteoporotic spine, medical and surgical management of osteoporotic spine. And I am sure this is a very, very important topic for all practicing orthopedic surgeons, spine surgeons, because there are a lot of dilemmas. It starts with whether we should give alendronate, whether I should start teriparatide or denosumab. It starts with what is the T-score, whether you need DEXA scan because there is already a fracture. There are so many variations in this, and you meet a rheumatologist, you meet an endocrinologist, you meet a senior orthopedic surgeon, you meet a junior orthopedic surgeon. Everyone has different assumptions about this particular topic. The same thing likewise in surgical practice, because someone feels that I should use HA-coated screws, I should use a long splinter, I use a long segment fixation, I should use dual core screws, these are having better results, I should use sublaminar wires. Again, there is no clear-cut consensus, but now I think with a lot of research, we are knowing reasonably good about the guidelines, how we should fix, where we should stop, what we should do. And we have a stellar faculty today for this spine symposium. First, I would like to request Dr. Gadegone sir to welcome everyone, as this is his academic initiative for betterment of everyone. And over to you, Gadegone sir.
So, good morning to everybody. I am Dr. Wasudeo Gadegone, President of Maharashtra Orthopaedic Association. This is the spine webinar we are conducting. This is the third episode, you can say, and it has been viewed by many orthopedic surgeons all over the world, not only in the Maharashtra. Now, this time we have two guest speakers. One is Dr. Saumyajeet Basu from Kolkata, and he is one of the well-known spine surgeons all over the world, and he is now a president-elect of a Spine Society of India. Another stalwart who is working in the USA, and to tell you very frankly, he is from a native of my district, Dr. Amit Bhandarkar, who is working in America. He is also will give us inputs from what are the modern advances in America. And as you know, all Maharashtra stalwarts of spine, Zaveri, Shailesh Hadgaonkar, Dhiraj Sonawane, and they are all very eminent figures, which we need not elaborate their this biodata. And I also welcome Nalawane sir. He is a rheumatologist, and he will also enlighten us what is the role of rheumatology in osteoporotic spine conditions. So I welcome you all, and I hand over to Shailesh for further proceeding. Thank you, sir. Shailesh, over to you.
Shailesh, unmute. Yeah, thank you, Gadegone sir, for this welcome address and blessings for the spine webinar. And I'll just brief about today's agenda. As we all know, it will be a head start with Dr. Gautam Zaveri, and I'm sure no one needs introduction, but Dr. Gautam Zaveri is practicing as a senior spine surgeon at Ashok Hospital, Mumbai. He is very active in Association of Spine Surgeons of India, and he is the secretary of Spine Society of India, and he is a prominent figure in the country and worldwide. He'll be talking about natural history of osteoporotic spine, what really happens to that bone. People talk about brittleness, people talk about glass-like. So this is what we want to hear from Dr. Zaveri's talk today. It will be followed by the next eminent speaker. Today we have Dr. Ajit Nalawane. Welcome you, Ajit. And he is a rheumatologist. And it's very, very important for all of us to understand what investigation we should do. A lot of time we see the BMD screening is done. Sometimes people say CT guided, someone says DEXA scan, and the medical management, which is always, I use zoledronic acid, I use alendronate, I use teriparatide, why not denosumab? All these things are there in everyone's mind, and you will be demystifying about the medical management and investigation. So that will be one of the very, very important talks for all of us. It will be followed by Dr. Dhiraj Sonawane. As we all know, Dhiraj is an eminent academic figure in Maharashtra and India. He is going to talk about vertebroplasty. It's a very commonly done subject. It's a very commonly done technique by many orthopedic surgeons, spine surgeons, but how we should do it and when we should do it. And this is again an important topic which Dr. Dhiraj will be demonstrating and discussing with us. And after that, we will have Dr. Amit Bhandarkar, who is practicing in the US, and he is from science background from LTMC, and he's moved to US and he's a consultant and in a private practice. Welcome you, Amit. It's a midnight or it's a late night in US. Thank you for giving us this great time and to be an international faculty on OrthoTV's MOA Spine webinar. He'll be talking about current trends, anything new, anything different, which they are doing it there in US. So that's a different perspective, which we will see from Amit. Will be followed by Dr. Saumyajeet Basu, who is the President-elect of Association of Spine Surgeons of India, one of the prominent academic figure in the country and worldwide. And this stellar faculty will be discussing about case-based discussions in osteoporosis. And it will be a delight to welcome you, Dr. Basu, for today's MOA webinar. Dr. Basu's case-based scenarios will be followed up by Dr. Tushar, and he is going to again going to give us very interesting and complicated spine cases in osteoporosis today. So that will be again a delight for this, because everyone talks about we should have a case-based scenarios, and we have kept more cases for this osteoporotic webinar. And I myself will be talking about revision strategies in spines, in osteoporotic spine, what all things which we can do differently or what all things are required. And most important, the current literature. Dr. Pramod Bilare is practicing as a spine surgeon at Sancheti Hospital, Pune, and he'll be demystifying the current literature, what's hot and what's not. So we welcome you, Pramod, for today's webinar, and we head start with Dr. Gautam Zaveri's first talk of today's show. Over to you, Dr. Zaveri, sir.
Good morning, everybody. At the outset, let me thank the Maharashtra Orthopaedic Association, Dr. Gadegone, and Dr. Shailesh Hadgaonkar for inviting me to this webinar. As Shailesh mentioned, that in spite of us, all of us orthopedic surgeons, seeing an increasing number of patients with osteoporosis and osteoporotic vertebral fractures, there is no common consensus as to how to treat these fractures and how to decide what is the paradigm for deciding what is the treatment. And that is what I'm in the next 7 or 8 minutes, I'm going to tell you, that it is not that difficult to make a decision once you know what is the natural history of a particular fracture or a particular disease. So this 70-year-old diabetic or hypertensive lady came to me with a domestic fall 3 days back. She had severe back pain. The pain was continuous, worse with any kind of movement, turning in bed, lying down to sitting, sitting to standing position. The spine was tender at the dorsolumbar junction. There was some tenderness in the lower lumbar spine also. Spasm was there, movements were painful and restricted, and the neurology was normal. The first question which comes to an average orthopedic surgeon who looks at this patient is, how should I proceed? Should I get X-rays, MRIs? Is blood investigations the way to go? Or should we start directly with non-operative treatment? This is probably an osteoporotic vertebral fracture. Well, in the decision-making algorithm, your first step when you see an elderly patient with back pain after a domestic fall is to always think of the differentials. The possibility of degenerative is always there in mind. Osteoporotic fracture, you should be ruling out infection, metastasis, and multiple myeloma. And therefore, the first test to be done is an X-ray. The common fallacy is people order an X-ray of the lumbar spine instead of ordering a thoracolumbar spine, and then your D11, D12, L1 gets cut off often, and you're not able to see clearly and you miss a diagnosis. So make sure that whenever a patient comes with this kind of a history, even if the pain is in the lower lumbar spine, you must get an X-ray of the thoracolumbar spine, APL lateral. This is your golden opportunity, as Dr. Nalawane will tell you, that when this patient has come to you primarily to identify osteoporosis and put them on appropriate treatment. And therefore, I use this opportunity to get some blood tests done at the same time in order to rule out other diagnoses like hypothyroidism, etc., multiple myeloma, in order to rule out other causes which may of osteoporotic vertebral fractures. But also, I want to plan what anti-osteoporotic medication to start. So I get a creatinine done because I know that zoledronic acid will not be very good in a patient who has a high creatinine. So, or if this patient has a hypercalcemia or a hyperparathyroidism, it may not be wise to start teriparatide. So these are some of the investigations we get done primarily. Now, this lady, which I just talked about, she had a fracture, as you can see, a superior end plate wedge fracture, which was there. And then, but she had no neurology, just severe back pain, only 3 days old. The question was, now how should I proceed? Should I get an MRI or CT scan? People, when they see this kind of an X-ray, they are very worried. Now, this is the type of X-ray where you should not really be worrying, because as you can see, there is no opening up of the posterior elements. So ligamentous failure is not there. The height of the posterior wall of the vertebral body is maintained, which means this is not a burst fracture. There is no neurologic deficit. So this is an innocuous benign wedge compression fracture with a superior end plate fracture, which is not going to go anywhere. And in this kind of a patient with a clear history of fall, I generally do not get any investigations done further except for X-ray blood test. And to decide on that, you should know the natural history of an osteoporotic fracture. If you get a patient who has 100 patients with osteoporotic vertebral fractures, about 63% of them go on to normal healing. What is normal healing? A normal healing means with a mild collapse or subsidence of the end plate, which is natural. Even in a young patient with a thoracolumbar fracture, the fracture collapses by about 8 to 10 degrees if you take an X-ray after 1 year. Similarly, what is collapse? Collapse is body is with gravity. It is body's attempt to obtain stability by bringing end plate closer to end plate and filling up the void which was created by compaction of bone during the fracture. So a collapse is normal. In some patients, the void is larger and they are highly osteoporotic. The collapse may be more significant. Even then, most of them will settle down to what is called as a collapsed healing. And therefore, in a sense, about 85% of your patients either are going to go to normal or collapse healing, but their pain will be relieved and nothing further will happen to these patients. It's only the remaining 15% of patients who do not heal. They go into a pseudoarthrosis. They have persistent pain, inflammation, pain which is on movement, that you should be worried about. About 3% of patients will develop a neurologic deficit. A large number of them do not develop neurologic deficit at presentation. They're on presentation at the time of the fall. They're able to stand up and walk. It's only about a week or 10 days later that they start developing difficulties in walking, imbalance. The orthopedic surgeon does not realize that this is because there is an L1 weakness and they are not able to walk because there is weakness in their legs. The patient's family too ignores it, thinking that this patient has pain. And then they come to us with a frank neurologic deficit, which happens in about 3% of patients. But the message here in the natural history is that 80% of their patients are going to heal on their own within a matter of 2 to 3 months. If you treat these patients properly, non-operatively, about 2/3 of these patients will have relief of pain within 3 to 6 weeks of their injury. So all these patients can definitely be treated non-operatively, and there is no need to rush into a surgical intervention. Can we predict these patients who are going to develop a collapse, the ones who can develop a late neurologic deficit? So the risk factors are, if the patient has an intravertebral fluid cleft, which means there is a pseudoarthrosis and there is fluid within, these are more likely to develop a collapse. Patients who have a posterior wall of the vertebral body is fractured, that is a burst fracture. Those where the entire vertebral body is involved, there is a significant hypointensity across the vertebral body. And those where there is a ligamentous injury, these are the patients who are more likely to collapse. You should be worried about them. If you plan to treat them non-operatively, keep them under close observation so that you don't miss out a neurologic deficit. Sugita classified osteoporotic vertebral fractures, but he defined that there are three types. The ones which are shown in pink, those with the swelled front type, the bow-shaped type, and the projecting type. These tend to develop progressive collapse and can develop a neurologic deficit, and these should be kept under observation and treated appropriately. So if my X-ray confirms a vertebral compression fracture, there are no other warning signs. What are the warning signs? If the patient has had the fracture without a history of trauma or a fall, there is a history of fever, weight loss, anorexia, if there is a past history of cancer or tuberculosis, the fracture is in the dorsal spine, not at the dorsal-lumbar junction, or there is an X-ray evidence of infection or tumor, then you should not wait. You can, if none of these warning signs are present, you can definitely start non-operative treatment directly. If there are warning signs, patient has not had a fall, there is some associated injury, there is a neurologic deficit, or with your conservative treatment, the patient's pain is increasing, then you should be worried and you should get an MRI scan. If the X-ray shows evidence of infection or malignancy, then obviously you need to treat it appropriately. If, however, there is no infection, no malignancy, no other problems, and the MRI confirms that this is in fact a painful vertebral osteoporotic vertebral fracture, I treat these non-operatively. If there is no response to non-operative treatment after 3 to 4 weeks, patient is still complaining of persistent pain, pain on movement, and there is no neurologic deficit, no significant deformity or intravertebral instability, I think of a percutaneous cement augmentation, and this could be either a vertebroplasty or a kyphoplasty or a vesselloplasty. In my book, I always do a vertebroplasty. I never do a kyphoplasty. I have never found this to be any advantage over a simple vertebroplasty. What are the contraindications for a cement augmentation procedure? If you find a compression fracture, even if it is hyperintense on an MRI, but it is asymptomatic, please do not go and do something about it. This patient is asymptomatic. If there is a patient who has a ligamentous disruption, then this is not going to be treated by your cement augmentation. This requires a stabilization. The remaining are relative contraindications. A large intravertebral defect, which means that there is a large void within the vertebral body. Here, when you do a vertebroplasty or a kyphoplasty, it involves injecting a large amount of cement. And these patients don't do that well because the cement becomes a rigid fulcrum over which the bone collapses. So whenever there is a large intravertebral defect, I do not like to do a vertebroplasty. Other relative contraindications are anterior or posterior wall defect, severely vertebral compression fractures. Remember about asking your patient about pre-existing respiratory disease. Often, though you may not realize it, there is microembolism during your vertebroplasty or kyphoplasty. And if a person is hanging on the balance with his respiratory disease, minor cement embolism which you and me may not have any problem with, may push this patient onto a respirator. So you need to be careful about these things. The last thing is, if this patient does have a neurologic deficit or a significant kyphotic deformity or a ligamentous instability, or there is any contraindication, as I have just mentioned, to cement augmentation, these are the patients in whom you must consider a formal surgery. So to conclude this talk, I think it is very obvious what I'm trying to get to, and that is that majority of your patients are going to heal without problems. And typically, majority of the pain will go down within 4 weeks. So the first 4 weeks, you need to manage this patient well, and he will go on to very good healing without any problems with minor or major collapse. Remember that stability, which means collapse, correlates with relief of pain. The moment there is collapse and bone touches bone, pain will actually get relieved. So don't worry about collapse unless the patient is getting a neurologic deficit or a significant deformity because of the collapse. If you are treating this patient and the pain is actually increasing or persistent after 4 to 6 weeks, always rule out infection and metastasis. If there is a burst fracture, a pseudoarthrosis, or a ligamentous injury, keep these patients under very close observation or treat these patients primarily with surgery or something to prevent delayed collapse. Vertebroplasty should be done in patients who have persistent pain without instability or neurologic deficit. Thank you very much.
Wonderful presentation, sir. I want to ask you 2-3 basic questions. What is your practice where how many days of rest you advocate in patients who come to the clinic? That's one. And something about the belt, brace or support.
So the first answer to the first one is I do not recommend bed rest.
Okay.
I allow patient movement within limits of pain. So if the patient is comfortable turning in bed, I don't mind. If the patient says I can stand and walk without much significant pain, I do not prevent, because bed rest does not prevent collapse of the fracture. The fracture is going to collapse irrespective of whether you give the patient bed rest or not. So in fact, bed rest is bad because you are actually enhancing the osteoporosis. Number 2 is bed rest results in rapid atrophy of muscles, which in these elderly patients is not a good thing. They lose confidence in walking, and then to rehabilitate becomes that much more difficult. So bed rest is not something I recommend. Activity within limits of pain is what I recommend. The second thing is, as far as bracing is concerned, a lot of these elderly patients are very fragile, very weak and thin. They do not tolerate braces very well. These are too heavy for them. Number 2 is a lot of them also have arthritis of the facet joints because of degenerative conditions. So when you give them an anterior hyperextension brace and push them into extension, the facet joints get loaded. That causes more back pain. And you must remember that how does collapse occur? Collapse occurs because of axial loading. No brace can prevent axial loading. So your brace is completely useless. I do not give braces to any of my patients with osteoporotic vertebroplasty. Okay. And most of them come with a lumbosacral belt, where the belt ends exactly where the thoracolumbar fracture is, actually causing more mobility at that level, if at all.
Gautam, but the patient is actually maybe a placebo effect, but the patient is happy if you have given something to the patient.
So I don't give it. If they want to wear it, I have no problems whatsoever. I don't insist on it, sir. What I have never done is I don't say that my way is the only way to the patient. If patient says, can I use a brace? Yes, use a brace if you feel comfortable. I have no problem.
Yeah, choice is to the patient, but there is not much of a role of a long bed rest, which used to be given by many doctors, like 4 weeks, 6 weeks, 2 months of rest. I have seen patients, and also belt, brace. You have to wear this. I have seen patients, couple, husband and wife, fighting because the wife is not wearing the brace, and they have big fights in the family because of the brace. So I think it's a practice. If there is a significant collapse and maybe a belt, a lot of people feel comfortable, then they can use the brace. So that's the clear message from Dr. Zaveri's talk. Any questions from any faculty to Dr. Zaveri?
Sir, so does BMD helps in deciding what kind of management you have to?
Not really. I don't find, I never do BMD again. It's a waste of money. Okay. Elderly patients have degeneration of the spine. There is a lot of osteophytes and all sclerosis. So there is often the BMD reading is fallacious. Number 2 is that the fragility fracture, once you have got, is a clear indication that this patient has osteoporosis and needs treatment. Now the question is, there are only, in the current scenario, there are 3 injectable medications and 1 oral medication which you can give for anti-osteoporotic treatment. The only place you could think of where you would want to do a BMD is to justify using of teriparatide, because some of the people say that if the BMD is more than -3, less than -3, then you think of giving teriparatide. But other than that, I don't think there is any reason for routine, because one of the problems with BMD is that when you do a baseline BMD and suppose you repeat the BMD after a year, and there is marginally, if the BMD is almost the same or marginally better, the patient says, I have had 1 year of teriparatide, but my BMD is not better, or I have had 1 year of zoledronate, but my BMD is not better. The end point of treatment of osteoporotic vertebral fractures with anti-osteoporotic medication is absence of new fractures. It is not increase in BMD.
And it just maintains the level, sir.
It might maintain the level. So if actually it doesn't go down, you should be happy. But patient doesn't realize that. And then patient feels that they've not got adequate and they stop the medication. So I don't do BMDs. I find it a waste of time.
Okay. A quick question to Dr. Basu. What is your protocol? You prefer to give bed rest to patient with fracture or no?
No, I don't ask them to take enforced bed rest.
Okay.
If they are comfortable in moving about, I would encourage them to move about. Because as Gautam correctly said, bed rest itself doesn't prevent collapse.
Correct. So I think message is clear. Yes, Dr. Amit.
With due respect to Dr. Zaveri and everybody, I think this side of the world, most of the time is totally opposite to what Dr. Zaveri has told. I will present in the talk, but nowadays we've been practicing literally aggressive medicine for those patients, and I will justify when I talk. So I think we can debate after that a little bit more. It will be interesting, a different perspective.
Amit, before I leave, I would love to have just get an opinion. So your circumstances are different in the sense that your patients are always willing for intervention. Our patients are never willing for intervention acutely. Number one. Number two, in your patients, finance is not a problem because they are all Mediclaim covered, insurance. So you all keep on doing kyphoplasties, whereas we find vertebroplasty gives the result, as good a result without any problems. So I suppose that may be the difference in treatment. Third is you all give aggressive teriparatide. Sometimes our patients cannot afford that teriparatide injection. And in your case, there is no family support. So patient has to be up and about immediately. In our case, the family does not even allow the patient to turn in bed, even when we say that you turn in bed. So our circumstances are a little different. I agree with you. So that is why the treatment may be a little different. But the basic principle, when we meet personally, I will tell you that kyphoplasty is the biggest sham that has ever been invented. Okay.
Thank you. Thank you.
Long words.
So we move on to the next speaker, and I invite Dr. Ajit Nalawane for enlightening. And this talk is "Dobara mat puchna, ek hi baar dekhna," because everyone will have different assumptions. So let's hear from horse's mouth. Ajit, over to you.
Thank you, Shailesh. Can I share my screen first?
Yeah, please.
I hope it's visible.
Yes, sir.
Yes.
Thank you, Dr. Shailesh, and thank you, Maharashtra Orthopaedic Association, for inviting me today to present this talk here. And it's really an honor and a pleasure to be talking today. So my talk deals with the medical management of osteoporosis, which is a very common problem for you as orthopedicians who deal with patients coming with the musculoskeletal problems, as also we rheumatologists. So most of the problems we face when we deal with the patient with osteoporosis, in fact, still have not been answered with very high quality, well-designed randomized clinical trials. And most of the advice, even in this talk, probably comes from the combination of available clinical evidence, non-trial data, and expert opinion, as well as the off-label use of medications. But I've tried to be as simple as possible without going into the complexities. And let me start with these three patients which I happened to see in last week when I was told to give a talk for this. And these are the common clinical questions probably you'll face when you treat your patients. So this is a 59 years female obese patient with rheumatoid arthritis, hypertension, diabetes, osteoarthritis, long-standing glucocorticoids use. She has been diagnosed osteoporosis in 2015 and on weekly alendronate for more than 5 years now. And she was seen last week and with acute and chronic back pain and X-ray suggestive of L3 fragility fracture. Now, just to summarize, patient has multiple comorbidities, 59 years female, already known osteoporosis on long-standing alendronate. So what are you going to do? So probably I'll come back to this at the end of the talk. So there's again another case, 68 years female, rheumatoid arthritis, osteoarthritis, osteoporosis with vertebral fragility fracture diagnosed in 2017 on denosumab since then. Patient currently has no complaints, but what about how long can we give denosumab and what do we do then? These are again the questions which patients will keep on asking us, especially in India where they have to pay for these drugs from their pocket. And this third case, seen yesterday, 77 years male, chronic back pain since 2 years, low body mass index, smoker, alcoholic, X-ray, no evidence of any fracture apart from some osteopenia. And in fact, no other inflammatory disease or diabetes. DEXA scan, T-score of -2.5 and hip score of -1.3. And the question whether you'll treat this patient. So coming to osteoporosis research. So what is osteoporosis? The first thing, the definition. So it's actually reduced bone strength because of loss of bone mass, reduced bone mineral density, and deteriorating microarchitecture. And that leads to increased risk of fracture. So in fact, until the first fracture occurs, bone loss is asymptomatic, suggesting that osteoporosis cannot be detected unless BMD is measured by DEXA scan. And in fact, the epidemiologic studies suggest that almost 40% of females and 19% of males will have an osteoporotic fragility fracture once in their lifetime. So it's quite a significant problem. It's a silent disease and it needs to be assessed or anticipated when you are seeing your patients to diagnose it early. And why do we need to diagnose it early? Because of course, hip and spine fractures are associated with increased morbidity and mortality and the cost. So always whenever you're thinking or assessing a patient with suspected osteoporosis and you have diagnosed the patient, we'll see what are the current diagnostic criteria, but you should always think whether this patient has a secondary osteoporosis. So most of the times, if patients are known cases of other diseases like rheumatoid arthritis and getting treated for the same, but osteoporosis is often missed. So the commonest causes of secondary osteoporosis include hypothyroidism, hyperthyroidism, chronic glucocorticoid intake, hypogonadism in some, alcoholism, and chronic diseases like rheumatoid arthritis. Especially in these conditions, you should always think of evaluating for osteoporosis and to decide whether such patients need any treatment. Now, these are the diagnostic criteria, basically, especially in postmenopausal female or an elderly male more than maybe 70 years. So if a patient has fragility fracture, as Dr. Zaveri suggested, you don't need any DEXA scan to diagnose or decide on treatment of the patient. So already patient presenting with already a fragility fracture, you just have to treat osteoporosis unless there are reasons that to avoid any treatment in such patients. So current guidelines and current recommendations definitely suggest these patients should be initiated on treatment. Now, if a patient is suspected to have osteoporosis based on the risk factors they have, but doesn't have any fragility fracture, then it is important to get a DEXA scan. And if the T-score of the patient is almost less than 2.5 standard deviations as compared to the mean of the young healthy adults, which is called as T-score, in fact. If it is less than minus 2.5, then there is a diagnosis of osteoporosis which needs treatment. But in case the patient has T-score between -1 to -2.5, then there is another utility that is called the fracture assessment tool. It's called FRAX. It's a free online tool to calculate the risk of fractures in the future, and wherein you just have to enter the patient details like age, weight, and other comorbidities, and the bone mineral density at hip, and it gives you a score, or it gives you a 10-year fragility, major osteoporotic fracture risk, whether it is more than 20%, whether it is between 10 to 20%, less than 10% or so. And even it gives hip fracture risk in future, whether it is more than 3%. So for diagnosis of osteoporosis, it has to be a high risk of fragility fracture in future, which is the FRAX 10 years fragility fracture risk of more than 20%, or 10 years hip fracture risk of more than 3%. So if it is so, you have to treat the patient and label the patient as osteoporosis. So these are the basic ways you can diagnose patient as having osteoporosis and needing treatment. Now, just a word about other techniques to measure bone mineral density, because there's a lot of confusion about this. At the outset, let me say it is the DEXA scan, which is currently the gold standard, because it has a very good precision to identify bone mineral density, and it can be used for monitoring. If at all you're using DEXA scan for monitoring, it should be done not every year. It should be done at least every 2 years or maybe 3 years, because you won't see any changes so early. So that is one thing, but it can definitely be used for monitoring therapy of patients with osteoporosis. Quantitative CT scan also has good precision, but it is expensive, and you can consider it in certain patients where you cannot do DEXA scan, say like patient has metal implant or so. Ultrasound, in fact, should not be used. It may be cheapest, it may be easy, convenient, but it has very low precision with the low, in fact, false positives, false negatives, and it cannot be used for monitoring of treatment. So I entirely discourage it to be used in patient management. Now, coming straight away to our options for treatment. In fact, the armamentarium is now increasing with the newer drugs being available. Just a quick word about all of them. So we have anabolic drugs or stimulators of bone formation. These are parathyroid analogs, teriparatide, which we very commonly use nowadays, and abaloparatide, not yet available in India. Then there is the sclerostin antibodies, which are recently included in the treatment strategies. And this is romosozumab. It is also very effective, not yet available in India. And there are these inhibitors of bone resorption. We have been using bisphosphonates and denosumab, other drugs which are now used quite often. In fact, estrogens and selective estrogen receptor modifiers like raloxifene are in fact not much used now because of their thrombotic risks and lesser efficacy compared to bisphosphonates and other available drugs. So just in short, something about bisphosphonates, and alendronate is the drug which we commonly use because it's oral and convenient to use and cheaper. Residronate is less effective than alendronate. Abandronate, in fact, doesn't have its efficacy in non-vertebral fractures. So unless any other reason, I would not use abandronate. I would prefer alendronate, of course. And zoledronic acid, which is better, in fact, in efficacy, even if you consider alendronate, but it has to be given once a year. And okay, next slide, we'll talk about the drug holiday. The commonest adverse effects are, in fact, dyspepsia and maybe abdominal pain, but nothing much to worry about. And what we are worried about is the rare adverse effects, which limits the long-term use of these drugs, like osteonecrosis of jaw and atypical fracture femur. Even though the atypical fracture femur incidence is quite less than 1 per 1,000 patient years, but still it is a problem and we need to consider it, especially if we are giving alendronate more than 3 to 5 years. Various high-quality studies have shown that bisphosphonates reduce vertebral, non-vertebral, as well as hip fracture by about maybe 40% a year. So, as already I have mentioned about the atypical fracture femur, there are some guidelines nowadays to prevent this rare adverse effect. It is recommended that bisphosphonate should be discontinued after 3 to 5 years if patient has no new fragility fracture in that duration, and the hip bone mineral density is not less than minus 2.5. You can reassess the patient after 2 to 3 years, decide if patient needs further treatment. If at all the BMD is worsening or there are other risk factors, you can again restart patients on bisphosphonate or other modalities of treatment. Now coming to denosumab, in fact, this it's been more than a decade now. This is available option for the treatment, and in fact, it is the molecule I prefer because it can be safely used for up to 10 years, and because data is to 10 years and lesser incidence of a typical femur fractures. That is once in 6 months subcutaneous injection. It is more effective than the other bisphosphonates. And the advantage is it reduces vertebral as well as non-vertebral and hip fractures. If you talk about teriparatide, it's not very effective in reducing hip fractures. It's more effective for lumbar spine. And so only the downside is if you stop denosumab, the bone mineral density again starts to fall very rapidly, and there has to be some exit strategy, like you have to put the patient again on bisphosphonates like alendronate, maybe within 6 months or so. So common adverse effects are transient hypocalcemia, a rare adverse effect, osteonecrosis of jaw, less commonly seen in patients we treat, more commonly seen in malignant patients where the doses used are high, in fact 3 monthly or so. But it is again a very rare adverse effects. So a typical fracture femur is very less likely with denosumab, but still it's a likely possibility. Coming to the parathyroid analogs, mechanism of action activates osteoblasts. It's daily subcutaneous injections. Current indications are severe osteoporosis in postmenopausal women or patients presenting with spinal fragility fracture. So they lower the risk of vertebral fractures and clinical fractures. So they're more effective than bisphosphonates, and adverse reactions include transient hypercalcemia. But there are contraindications. You have to rule out a condition like Paget's disease, in fact, for increased osteosarcoma risk. And in patients with prior radiation therapy, you have to be careful. So current In fact, currently it is recommended not more than 24 months duration. So it's a once in lifetime use you can do, but not more than 2 years. Now, this is the new kit on the block, still not available in India, but it is more effective than all available options. It's a sclerostin antibody which activates WNT pathway. And in fact, it binds to sclerostin, which actually blocks osteoblast function. So it's given monthly, subcutaneous, and we're looking forward to use this molecule probably in future, but there is one caveat: it has higher cardiovascular risks, probably increased thrombotic events. So it has to be avoided in patients with recent cardiovascular event or patients with high cardiovascular risk. So just putting it all together, whenever a patient you're suspecting of osteoporosis, a DEXA scan, if minus 2.5 t-score, you can label the patient as osteoporosis and consider treatment. But if the t-score is between -1 to -2.5, then you have to go for FRAX 10-year major osteoporotic risk. If it is high risk, that is more than 20%, or the fracture risk of hip is more than 3%, you again go ahead and treat this patient. So the current guidelines and current evidence is for postmenopausal woman or elderly male. There are slight differences. Usually postmenopausal women with moderate to high risk, first line drugs are alendronate or zoledronate. Second line, in fact, if for any reason, you can consider ibandronate or naloxone. But if there is very high risk, you can consider parathyroid or teriparatide or other anabolic drugs. In men, there's slight difference. The moderate to high risk, you can use bisphosphonate, but in patients with hypogonadism, there is a role for testosterone there. And patients with very high risk, which is based on FRAX analysis, teriparatide, denosumab, and zoledronate. In fact, what I mentioned, I failed to mention in the postmenopausal woman, it's a typing error. Denosumab is also a first-line drug here. So coming back to the first three cases, so comorbid patient, chronic glucocorticoids, weekly alendronate, but has presented with a fragility fracture. In this patient, I will definitely consider initiating this patient on teriparatide. Of course, we have to stop alendronate. The second case, denosumab, appears to be quite safe, so it can be continued at least for up to 10 years. And even if when you consider stopping denosumab, you should have some exit strategies, like by around 6 months, you can initiate patient on zoledronate or maybe alendronate. And this elderly male who is smoker, alcoholic, apart from lifestyle modifications, based on the guidelines, you should initiate this patient on treatment, but I would go for patient preference. If he can stop smoking, alcoholism, and some strengthening exercises, maybe even that could be an option. But actually, this patient should be treated with alendronate also. So thank you for your patient listening. I'm open for questions.
Yeah, very elaborate and detailed talk, Ajit. A lot of learnings. I would like to ask Dr. Saoji, what is his practice when a patient of osteoporotic spine comes to your clinic? How you decide, and which are your favorite drugs?
First, as the Ajit said, the investigations first is X-ray.
Okay.
Followed by then anti-osteoporotic drugs, mainly we give bisphosphonates.
Okay.
And because we don't have access to denosumab.
Okay.
Nalawane sir,
Yes,
is there any role of vitamin D and calcium supplementation?
Yeah, of course. In my talk, I failed to mention. In fact, patients should have adequate calcium and vitamin D supplementation when you are considering osteoporotic treatment.
And what about
but on its own, on its own, it would not be sufficient to treat osteoporosis. But those patients, say, like who just have osteopenia or maybe are having higher risk, but still not in the definition of osteoporosis, you can give calcium, vitamin D, and strengthening exercises and lifestyle modifications. But once patient has osteoporosis, the three criteria which I mentioned, then you have to treat with at least bisphosphonates or other drugs based on your clinical judgment and patient preference, of course.
So vitamin D should be given orally or injectable. Nowadays, orally also is equally.
This platform, I would like to make it categorically clear that vitamin D injection should not be given intramuscular. In fact, you can tell the patient to drink it orally for the simple reason it's a fat soluble vitamin, and it is well absorbed if you drink it. You get those injections. So the problem with intramuscular injections is, in fact, the absorption is erratic and it is painful. So you have a better.
But lot of orthopedic surgeons, they are using vitamin D still injections.
Yeah, I know. Yeah. So that strategy should be changed. So if at all, say like it comes in 6 lakh units ampule, but if the patient has very severe osteoporosis, nowadays it's that we don't use 6 lakh units, but if at all you want to give it, tell the patient to drink it. Okay, not more frequently than 15 days.
Nano shots, liquid.
So you can, but 60,000 units of every week, not more than 2 months or 3 months maybe, is what is recommended. We should not keep on giving it also, because as you all know, fat soluble vitamins can cause hypervitaminosis and toxicity as well. So nowadays almost everybody is prescribing vitamin D. So whenever a patient comes to you, just inquire whether gynecologist has prescribed it, whether a GP has prescribed it. So in a year, if at all, you can give it monthly 60,000 units, or if it's weekly, not more than 2 to 3 months a year.
Thank you, Dr. Nalawane, for an excellent talk. And in view of time, we will have to go for one of the most awaited talk for the symposium today. I invite Dr. Dhiraj Sonawane to share.
Can you see my screen?
Yes.
Thank you, MOA. Thank you, Gadegone sir. Thank you, Shailesh, for this invitation. I am Dr. Dhiraj Sonawane. I practice in Grand Government Medical College. It's one of the oldest institutes in India. So today I am going to talk on vertebral augmentation, when to do and when not to do that. So as we all know that vertebral augmentation has been developed. This is a cemented augmentation has been developed since 1987, almost 40 years plus. And the first generation was developed by Galipert. It was a vertebroplasty, a simple injection of vertebral body cement with the help of needle was been done. So the commonly used word is a vertebroplasty, what we all do still now. Okay. It's usually a practice that the first generation usually goes out of trend over the period. But
Is there some network issue?
Yes, there is a network issue. He has to stop the video.
Yeah, Dhiraj, can you stop and reshare? I think we can come back to Dhiraj. If everyone permits, we will go to the next presenter, Dr. Amit Bhandarkar. And Amit is practicing in US as a spine surgeon in a group practice. And he's from Nagpur. And we are looking forward for current trends and what latest is happening in the US and your practice. Over to you, Amit.
Thank you, Shailesh. Thank you. Let me share my screen here. All right, thank you very much. Thank you. It's absolutely a pleasure to be a part of this extremely talented group. And thank you, Dr. Gadegone, especially for getting me involved here. I'm going to offer different perspectives. It may not match with the current practices in India, but just take it with a pinch of salt. There are a lot of different forces that usually do dictate how you practice. So it's my sincere request to you guys. It's a different perspective. Just take it with a pinch of salt, and maybe you may gain some insight into what is coming based on this perspective. So far what has been talked about, it's a little bit aggressive perspective than that. So I'm going to go with a case-based discussion. So this is a patient who has come to me relatively recently. So she's waiting for surgery for 6 weeks. She has a grade 1 spondylolisthesis, severe stenosis. And then she presented to the ER with a compression fracture. The ER physicians that are here, they just do CT scan. Severe pain. Her complaint is severe leg pain. So I'm kind of confused when I get a call. I said, hey, why don't you get an MRI of the patient? So I asked them to get a lumbar MRI. The new MRI, as she's waiting for this MRI of the CT scan, she develops another fracture there. So she develops a fracture of L4. She has severe stenosis, severe radiculopathy. These are the common patients that sometimes we get here. I think I'm just going to talk about the current trends and what should we do for this kind of patient. So let's discuss about this patient's management at the end of the talk, maybe end of everything, and see how many different perspectives we gather. So why this topic is so relevant today, why it is so relevant. So I would like to dismiss Dr. Zaveri's talk by saying 80% get better now. There's a lot of relevance to this talk today. There is change in demographics. In US, it's totally changing. And the average people are very old here, and so is going to happen in Asia. Most of the osteoporosis in the world is undetected. Why it gets undetected? Because we orthopedic surgeons never order a DEXA scan. It's also very underrated because, a spine fracture, they still are going to walk. But when it develops in the hip, then they almost die if you don't treat them. The burden is immense. The amount of people staying in the hospital longer time are the people who have severe osteoporosis. They usually give you a chance to treat the osteoporosis beforehand when they present with some fracture like wrist fracture. We neglect it. As physicians, we have the responsibility. I think there are very few physicians who do a DEXA scan to understand the underlying disease if the patient presents to us with a wrist fracture or even a fragility fracture or even a hip fracture or even any other fracture. We don't do it. So it's underrated, undetected. Demography is changing. We are going to be practicing old people medicine. The old people are going to quadruple in pretty soon time. So we should be ready for this. So this is very relevant. So currently I'm trying to go ahead and divide the scenarios that I'm going to discuss into 4 types. First is simple osteoporotic compression fracture. What we do about it. Second is the patient comes for adult spine surgery. Do I screen for osteoporosis and how do we do that? And second thing, if the surgical patient, as we had before, if the patient is osteoporotic, how do I do justice to the patient's osteoporosis when I'm treating these patients? And third is complications after adult spinal deformity, like in the form of PGK that happens in people who have osteoporosis. So these are 4 sections. So I'm going to run through this because I don't think so I will be able to finish this in due time. Okay. So let's start with one more patient. This is a simple patient. We are around 78-year-old female, history of fall, trivial fall, compression fracture. Done a CT scan in the ER, standing X-ray shows quite a little bit of collapse, not much. So how do we investigate this patient? So there are two types of investigations we do. One is catering to the disease which has caused the fracture, which is osteoporosis. And the second is the radiological investigation for the surgeon who is treating it. So we understand the primary disease here is not the fracture. The primary disease here is osteoporosis. Now, she has presented me with the opportunity to investigate her osteoporosis. So I'm going to throw everything at her. We usually get the DEXA scan score done. We do the trabecular bone score. We get the CT Hausenfeld unit score. We also, I'm very fortunate to have an endocrinologist nearby. I refer them to endocrinologist. I get sometimes oncologic assessment if there is a criteria that she meets that. Then I also do, if there is any risk factor like she's a smoker or something else, or kidney disease, then I do a modified risk assessment. But we do FRAX. So all this DEXA, FRAX, TBS, CTHU is done by possibly the endocrine doctor. I don't need to worry about it. I don't know much details about it, but I make sure that that's getting done, because she's going to treat that patient for maybe good amount of time, because she's now will be diagnosed with osteoporosis because she now has fragility fracture. From my side, I take standing X-rays. I do MRI because I want to know the patient's pain is new or old. Usually the patient does come with a CT scan when they come from the ER. So when there is a doubt, I prefer MRI over the CT scan. Now, we go by algorithm. We do not go by individual discretion usually, and that individual medicine should be the way of medicine. But there are some algorithms that I would like to state here. One of the good classification that came from German Orthopedic Society is the OF classification. It's a pretty simple classification, pretty high inter-observer reliability. If you see this classification, it divides into if there is a superior end plate, if there is a posterior wall, or if there is a posterior ligamentous injury. So posterior ligamentous injury is OF5, OF4 is kind of pincer, 3 morphological types. OF3 is severe compression of the anterior end plate. So I think our patient has possibly OF3. Then we do the scoring as we do in TLIC scoring. So we have a good amount of scoring experience now. I think the TLIC score is pretty widely practiced in India too, I guess. Here we do what we call as the OF scoring, and if you see that we can add few points. Usually the morphology gets 6 points here, 2 points for each level of morphology. The T score is not available right now, but the patient has severe pain, more than 4. Patient is totally not mobile, add 1. And patient has also increasing kyphosis. We add at this sub, the patient score is 9. If the patient score is more than 6, the patient becomes surgical candidate. This is a very good classification system, just tells you what to do. So what are the goals for surgical management? It's pain relief, vertebral stability, early rehabilitation, body restoration, sagittal balance, treating underlying condition, preventing complications of inactivity, and prevention of further fracture. Before I go this in here, just to counter everybody, and in terms of surgical treatment, we do give conservative management here, and I think we do not give with the conditional management, like we will do first conservative management, then only I can do surgical management when it fails. It's not like that. So surgical management is decided by the algorithm. Patient also gets simultaneously conservative management. So if the patient's OF score is less than 6, patient only gets conservative management. If the patient's OF score is more than 6, patient is more likely to get both. So calcitonin is shown to reduce pain, so that everybody gets in my practice. We get oral opioids, so that really helps with the patient. Brace is totally optional, as we agree with that with everybody. I usually do give patient a brace because they feel comfortable with that, especially in mobilization. the intra-abdominal pressure increases, and that really helps. We don't do any bed rest. Early mobilization is the rule. Sometimes people are very unfit for surgery. People may get a medial branch block. So surgery justification against is a very important slide. Why we have been so aggressive about surgery is the question. So the first thing, it's the data is outright there. The data is outright there. Data says that there is an immense mortality benefit. What does that mean in layman's term is that if you do not do early intervention in this patient, considerable number of people are going to die in coming 10 years. So these studies are out. The anabolic drug studies have given 11% of mortality benefit over 10 years. Some studies with kyphoplasty has shown around 40% of mortality benefit. That is an overwhelming number. You will be burdened of not doing it. So you will be ultimately be the reason for the demise of the patient if you don't treat them early. So you have to think it the other way. So there is an overwhelming data of pain relief. There have been meta-analysis of quality studies done, and all the data said there is good amount of pain relief. No data says that it's bad, especially with kyphoplasty. I know there was a little bit of confusion about those Veritos trial, and I think that was the main reason why it put away people from this good procedures. I think these are the only procedures that an orthopedic spine surgeon does to save life. I say that. We save life by doing these procedures. And they are very cost effective because it prevents a lot of subsequent complications of admissions to the hospitals for other things. So I will explain that. You have to see and understand the concept of sarcopenia, dynapenia, and frailty to understand how it prevents mortality. So sarcopenia means low muscle mass, dynapenia means low physical strength, and ultimately it leads to frailty, which is the end point of sarcopenia. So sarcopenia is assessed by the paraspinal muscle mass. So what happens when the paraspinal muscle mass decreases? There is high risk of complication, even death. There are multiple studies in last 5 years. If you Google out on PubMed sarcopenia, the number of studies have been more in last few years. This is a new concept, but very well understood because we neglected muscles all the time. So if the sarcopenia develops, the patient becomes frail. A frail patient does not recover easily from anything. Pneumonia will kill him. So you have to understand that we are dealing with these old patients. So now we also have to throw into the mix the sagittal balance. So sagittal balance, it has been shown by Glassman that kyphosis or any kind of sagittal balance increases your ODI score. It's directly related to your functional outcomes. So anything which is kyphosing causes very poor quality of life. So in my practice, putting the data together, putting the evidence together, I think we tend to operate the patient as early as possible. If the OF score, which is the objective data, it's not a subjective data, is more than 6. Why? Because patient can lose around 2% of bone mineral density in 1 week of inactivity. Patient can lose 50% of muscle strength in 6 weeks of inactivity. Restoration of body height is better if done early. Early mobilization is possible if you do kyphoplasty early. Very few chances of cement leak if you do early. Very few chances of osteoporotic second fracture if you do kyphoplasty early. Why is that? Because the kyphoplasty second subsequent fracture happens because patient goes into a kyphosis, and the kyphosis is the reason why the patient develops fracture. Why the patient goes into kyphosis? Because he develops sarcopenia. So this is how it naturally progresses. You don't want to treat the patient here where the patient is progressing and causing a fracture at the other location. You want to treat them aggressively earlier because the data shows that you are going to give a patient a mortality benefit. You don't want to make a 70-year-old bedbound by any means. So So what are the options for treating them? There are a lot of options nowadays. There has been a kind of explosion of implant innovation in spine surgery in the last 10 years, especially in the US. There are a lot of what we call as vesselplasty, body height restoration. This is one Kiva, balloon kyphoplasty, expandable cages. So what is my favorite? My favorite is what I use in practice is spine jack. Why do I use spine jack? Because there's a Seiko's trial which says that there is a great superiority when they compare kyphoplasty to this, is that there is absence of adjacent level fracture. The vertebral body height restoration, kyphosis correction is pretty efficient with this, and there is less cement extravasation. So this is a patient. I go ahead with the drill. I use bilateral. Bilateral is always better than unilateral. I do that. Then I go ahead and inflate this spine jack. Then I put the cement in. I use high viscosity cement. I don't use the low viscosity cement because there are chances to leak. This is how it looked like post-op. So I do always bilateral. As I told, it's for subsequent thing. We plan for 1 year down the line. Even though you can do it with one side parapedicular approach, but it's always better to do bilateral, better kyphosis correction, long-term better pain relief. So there are different trajectories that you can take. You can take parapedicular approach, superior. Anybody who is doing pain management has multiple corridors of access to that area. Sometimes I've been thinking about the transcambin access for the inferior end plate. That sometimes is critically important when you do a cage. So this is how usually I wanted more medially, but this patient's pedicle was very, very, very thin, and this is what she got. So how much cement volume do we inject? Sometimes when vertebroplasty people just keep on injecting. So it has till you get good feel all around. So usually it has been found out that if the cement volume divided by vertebral volume is more than 13%, there is a high chance of leakage into the venous system, and it does not add any advantage. So how much to expand? I expand completely. This is the vertebral plana. This is completely opened up. So there are some surgical tips that I put around. Say some of the patients, when the vertebral superior end plate breaks out, what we do? I use a warm water bowl, and in that bowl I put 2 cannulas in there, so that the cement sets it pretty quickly. I go ahead and put that cement there first, and then subsequently go to the other areas. So, but sometimes we don't resolve the pain because there are other reasons. We need to be very cognizant of that. Sometimes there is a new fracture and the patient comes back. This patient should get an MRI pretty quickly. But I think I'm aggressive about investigating this patient because they have a high chance of getting a subsequent fracture done. Now, for OF4 fractures, I think we can do a small segment instrumentation with cement augmentation with kyphoplasty or vertebroplasty at that location as well. This is me doing a long segment for OF5, totally done percutaneously with multiple level screw augmentation. So this completes the first part about how do I treat the compression fracture. I think the major difference is that how aggressively I treat them early. And I was able to tell you the reason why you have to see those patients with the eye of sarcopenia and positive sagittal balance. Now screening for osteoporosis. So let's go to one more patient. This patient came to me scoliosis with a history of vertebral compression fracture, grade 1 spondylolisthesis, but our complaint is not back pain, severe radicular pain. This is the patient which shows again the compression fracture, severe radicular pain. You should look at the L4-5 in the right parasagittal area, severe stenosis, severe radiculopathy. Obviously, I think the current symptom is more of a radiculopathy. Now, I have identified the pain generator. The patient's DEXA is -2.6. The patient got facet joint injection, did not get pain relief, but the epidural injection completely relieved her pain. So now the patient's pain generation has been detected. Now, what should I do with this patient? This patient is osteoporotic, already had a fragility fracture. And now I am planning to do a surgery on this patient. Now, how do I optimize this patient is the question. How do I optimize this patient, or how do I go ahead with treating this patient? Should I go ahead and do surgery immediately, or should I go ahead and optimize it is the question. So this is a good guideline that came up from UC Davis recently, 2021. And I think I just quoted it up here. So usually what they do for any surgical patient, for a routine elective spine surgery patient, anybody who is above 65 or who has this criteria, they get evaluated further by a DEXA scan. Obviously, everybody knows what DEXA scoring looks like. There's a TBS score, or trabecular bone density score. It can easily be done at the same time as DEXA. It's just a software that is added to the DEXA machine, which gives you a TBS score, and it gives you more understanding how the patient's fracture is going to behave. We can also use a CT Hausenfeld unit. If they are below 50, the patient is really osteoporotic, for the CT scan that you do. I also get the gait speed from the physical therapist. If it's less than 0.8 meters per second, the patient is sarcopenic, or if the patient hand grip strength is below 18 kilogram, the patient is sarcopenic. What does that mean is that the patient is really going to have trouble getting up from the bed after the surgery, even though no matter what surgery I do. So I'm kind of guesstimating that this patient is a very high risk for frailty, and this I think I need to optimize her before I do surgery, because surgery is going to add insult to the assault, So objective assessment of sarcopenia is done by doing what is known as skeletal muscle index, or psoas index. Also getting the psoas area value. I also measure vitamin D, optimize it to around 25 to 30. So how do I optimize them? I treat them with vitamin D, amino acid. I actually take help of that endocrinologist that I have. I tell her I need the patient to be optimized. Sarcopenia can be optimized by resistance training. Sometimes they need some hormones. If the male testosterone really helps. I'm a great fan of anabolic drugs, especially the abaloperitide and also teriparatide. I asked them to go ahead and start it at least 2 months before the surgery, to be continued 6 months after the surgery. There was a debate at one time, how does patients with fusion do after bisphosphonate therapy? Because they stop remodeling and all that stuff. So there is some data out now, not very clear, but some data says that it really helps with the fusion. So I can still give Prolia or denosumab to this patient now. Initially, I was reluctant. I would only ask them to get teriparatide. Obviously,
yeah, hi, sorry to interrupt. We are really having a couple of talks, and we need to control.
I'm just going to go ahead and just run through it in 2 minutes. So this is what I did. I did what we call as a transcambin optimish device, which is a bag of bones. This is other patient where we can do, this is not my patient, we can do cement augmentation before we do a ALIF. This is what we did for the patient. Now, for osteoporotic spine, so this is one of the patient with severe osteoporosis, failed back surgery, uninstrumented fusion, and DEXA of -3.2. Now, what are the options we have? This is the history of patents. I try to search the patents that are coming up for osteoporotic screws. There are different kind of screws coming up, threaded, curved, expandable, cement, or bone ingrown anchors. This is a curved, flexible screws, different thread systems, different curvatures. Obviously, cement augmentation is the rule now. There are different screws, even HA coated screws, and I try to use them based on their femoral neck bone density. If it's less than -2, I will go ahead and use them. There are HA granules available. Should not be used for all the cases, especially as I said, if the BMD is -2 for the femoral neck, then I use it. Obviously, these are some of the systems that I have access to. This is again current trend. We have 3D printed what we call as truss gauges, which does prevent subsidence. Here, they're pretty kind of integrate easily. Now, there's a new device out there which you can have it titrated to your bone density. They will ask how much your bone density, and they will 3D print a device for you. So this is the device. This is the other patient that I did, where I did what you call as back of bone or optimization. An 85-year-old lady. I was able to do a disc height restoration on her. Again, this is, you can augment the end plates with cement by doing an anterior lumbar body fusion, and then can put a device in there. So rods, there are titanium, PEEK or carbon fiber reinforced rods are favorable. So this patient got this from me. I went ahead, I did an expandable lateral cage. So I think I gradually expanded the patient to its position, put the screws in, and then went back and then cemented him and put the screws. But I think I was a little lousy and used the cement more runny. And this is what he got. He got a cement embolism. So this is one of the, this was done early in my practice, and I think I got better now. So what are the increased chances of cement leaks? If there is vertebroplasty, thoracic vertebra, cement volume, more than 3 vertebra, venous cement leakage. This patient did just fine. But maybe this is one of the examples from the internet where if this thing happens, it's a catastrophic thing. The patients can die from that. So you have to be very cognizant about when you're doing multi-level cement augmented screw, that you with high viscosity cement, go slow. Make sure you do washouts. Make sure you have a bioplanar thing. Go ahead and do that. I think this we can save it for the next talks. This is from Dr. Sen Gupta, who talks about specifically about his system of preventing proximal genital kyphosis. I would like to show his main technique is this one. If you see that he puts a hook in the interlamina and then use a very acutely angled trajectory in the pedicle screw. This may interest you, Shailesh, you know, and he does that, and he does a kyphoplasty about that. He says that this usually does not fail. So even after doing in patients with Parkinsonism and patient on anti-epileptic drugs. So this is, so again, in the end, same patient, we'll discuss what do you think I should do.
Yes, Dhiraj.
Yeah. Can I enter?
Yeah.
Thank you.
Oh, Amit, it's a wonderful talk, and it's a very good perspective what is going on in America or in a very developed country. But probably what you talk about it is very good to listen, but very difficult to practice in India. But it is a very good thing that the new things are coming up. And thank you very much for participation in the Maharashtra Orthopaedic Association webinar.
Thank you, Amit. I missed Amit. I thought he is less aggressive than us. So I was looking for more conservative line of management. But
no,
I think
Dhiraj, just to interrupt, the questions which Amit asked, I thought I had to ask you. That's the reason I said yes, Dhiraj. But I must compliment Amit for a wonderful talk and a lot of advances, what he has shown and what they're doing it there in the USA. I think a lot of learnings, different type of screws and the stabilizing system. So thank you, Amit, for a wonderful presentation. And for that patient which you showed, I think lumbar, there is listhesis and stenosis, there is fracture also and a dorsal fracture. But you said the patient is having only leg pain. So probably I will consider leg treatment for the lumbar spine treatment for that particular case.
All right. I think we should discuss about it at the end. I think I've just took too much of your time.
Yeah. We'll proceed with Dhiraj's talk on vertebroplasty, which got interrupted because of some technical reasons. Over to you, Dhiraj.
Yeah, so I was talking about the generations of vertebral augmentation methods. So the first generation is the standard vertebroplasty. It still is the one of the most common procedure done for vertebral augmentation. After which balloon kyphoplasty came, which promised improving the height of the vertebral body, fracture body, and improving the kyphosis and getting the better sagittal alignment. But in long-term process, the study haven't been supporting that. The third generation came, which is the stenting procedure, spine jacks, osteofix, and a few procedures has been shown already by our colleague Amit. So this is a standard vertebroplasty generation 1, and it is one of the commonest procedure done for osteoporotic fractures. And this is a vertebral kyphoplasty, where a balloon is inserted through transperticular approach, and a void is created by expanding the balloon, and the balloon is retracted, and the void is filled with a cement. It has the only evidence it has shown till now, apart from the previous promises by improving the spinal alignment and vertebral height. The only promise it has shown is the reducing the leak of cement. It is found as per the evidence the leakage is less. So these are the other procedures, the stent procedures, which has already been shown by Amit. So this also promises the similar thing, improving the spinal alignment, improving the vertebral height back to near normal. And these are all the different devices which are coming up. Though they are very costly, we haven't using this as much as what Dr. Amit used in his part of world. So vertebroplasty is defined as a internal augmentation of fracture vertebra through direct intraosseous injection of bone cement into the vertebral body in order to provide stability and reduce the pain. The aim of the procedure is to reduce pain, possible restoration of vertebral height, and prevent further vertebral collapse. The prevent further vertebral collapse is important. The possible restoration of vertebral height doesn't go that much with the vertebroplasty, especially the more selective we have been in vertebral augmentation technique. I will discuss in further slide. Restoration spinal alignment is more with the third generation procedures, and early diagnosis of a fracture through a biopsy is important. So I must tell all my ortho colleagues through this webinar that when we think of vertebroplasty, vertebral cement augmentation, we don't look into the biopsy part. So I will insist that biopsy almost always should be done in every cases of, even if it is a standard typical looking osteoporotic fractures, because even with a typical looking osteoporotic fractures, the literature has shown that even a 4% of patient has been showing to have malignancy. So why vertebral body augmentation is required? Because 9% of loss of forced vital capacity happens with each vertebral body fractures. Okay, there is physical, functional, and psychological impairment, and many times we just got call from this relative of a patient that my elderly female, typically not moving or not able to sit out of bed, and the lumbar X-rays are looking normal. And these patients inability to move in bed should always give suspicious of a vertebral body fracture, which happens at a dorsal lumbar junction or slightly higher, and which might be skipped in a routine lumbar spine X-ray. Okay, there are other complications like due to immobility, like atelectasis, pulmonary complication, DVT, pulmonary embolism, UTI, and worsening of osteoporosis, as well as the muscle mass wasting, which happen after 4 to 6 weeks of bed rest. These are painful fractures and refractive to conservative line of management, especially with severe osteoporosis. They may require hospitalization for pain, and progressive loss of vertebral height is very commonly seen. They may happen there may be multiple fractures in a single patient, and also we have to look for other pathological causes like malignancy, secondaries, myelomas, hyperthyroidism, hemangiomas. So these are the typical patients for osteoporotic fracture when they present with back pain. X-ray, typically if possible, standing X-ray should be done. MRI and CT may be added after the X-ray shows something. One should apart from just lumbar spine X-ray, one has to go look for dorsal-lumbar junction specifically and above as well. If this patient has severe pain and not improving with conservative treatment for after 4 weeks and not happy, the pain component is not improving, she is not able to come out of bed, one should consider vertebroplasty. But if the patient is having a tolerable pain and on follow-up X-ray the fracture looks stable, then conservative management do work. But on follow-up X-ray, if we see progressive collapse, then we can think about vertebroplasty to prevent further collapse. So this is a typical patient which has vertebroplasty, in which vertebroplasty was done. You can see the amount of collapse which was seen within a week of follow-up, and it was not improving on conservative line of management. We have considered this for a vertebroplasty in future. So these are other cases where vertebroplasty can be done. So when not to do is also very important. When there is a burst fracture, where there is a retropulse fragment, there is a chance of cement leakage, especially into the spinal canal, and it may give into neurological deficit. A symptomatic patient with a tolerable pain, and he's already out of bed and he's improving with the conservative line of management, one should not consider these vertebral fractures for vertebroplasty. If patient is having uncorrectable coagulopathy, a local signs of infection, a severely compressed fracture, I will show in further slides what kind of fractures are severely compressed fractures. If there is posterior element involvement or a ligament involvement as well as in the they are not ideal candidate for only vertebroplasty as a treatment modality. When there is complete destruction of the vertebra, especially in lytic aggressive lesions, the cement may just flow around and may not hold into the vertebral body. If there is an anterior breach or end plate breach, there is a risk of vertebral cement migration. So this is a case, typical case, even with a typical osteoporotic fracture, you can see there is a huge void. There is a end plate fracture as well as anterior defect. These are even with osteoporotic fracture, this is not a very typical, this should not be a case which should be considered for vertebroplasty. This is another example where there is a posterior end plate fracture as well as a posterior retropulse fragment. These are also not the patient to be considered for the vertebroplasty. Other cases when there is an allergy, in that cases, I have commonly used, especially when there is no for vertebroplasty, then I prefer to use autologous iliac crest or the locally available lamina and spinous process graft through a transvertical approach. I try to put inside the body and may add anchorage above and below with the help of pedicle screws. So these are the other techniques of vertebral body augmentation with the help of artificial or synthetic bone grafts. The key learning is vertebral body fractures are hallmark of osteoporosis, and cement reinforcement is important, especially in pain point of view and early mobility and providing stability to the fracture and prevent further worsening of collapse. As Dr. Amit mentioned, high viscosity cement, which is a typical vertebroplasty cement, should be preferred against a low viscosity cement. And low viscosity cements are typically used for joints, which was the initial practice done by few orthopedic surgeons. Injecting the same cement used for arthroplasty has been used for the vertebroplasty, and there are chances of leakage and embolisms has found to be slightly high. Also, the settling time is quite low in these patients. Comparison of vertebroplasty with kyphoplasty, as RCTs has suggested, there is only advantage of preventing the leakages, reducing the leakages down. However, getting the sagittal alignment vertebral height is not what it has been promising. So the meta-analysis has showing vertebroplasty compared with kyphoplasty and conservative management. Against conservative management in selected cases, vertebroplasty and surgical management has shown to have much better advantages against the conservative management. Risk factors of pulmonary embolism. So the risk factor increases, especially in thoracic vertebra, when there is 3 or more vertebral body which has been injected, and when there is a venous cement leak seen at the time of injecting cement. Okay. Also, the volume of cement. If the volume of cement is more than 4 cc, one has to be avoiding inserting more than 4 cc of cement at a time. So this was a typical patient of osteoporotic fractures, not improving conservative management. There was 2 fractures, one at the lower thoracic spine and one at the lumbar spine, second lumbar vertebra. And this was typically only tackled with the help of cement. So there is another case where patient has thoracolumbar consecutive fractures at 3 or more bodies, and the T11 fractures was not healed, and it has showing pseudoarthrosis, and there is a big opening anteriorly. And here we are in such cases when there is an anterior big void and significant collapse. Here we prefer intra-body bone grafting with the help of fixation. So this was done in this patient, and he has done well. So the take-home message: always do a biopsy, as there is a 4% risk of malignancy. The patient indication and the patient selection is extremely important, especially a 4 weeks of conservative trial should be attempted in most of the patient. If the fracture is not healing, then it should be considered for a procedure like vertebroplasty. One should be aware of contraindications and look for cement leakage during insertion of the cement. And high viscosity cement should be preferred against the low viscosity. The volume of the cement per vertebra should be between 2 to 4 cc, and one should avoid excessive injection of the cement. Thank you.
Thank you, Dhiraj. It was a nice and elaborative topic and talk on vertebroplasty. Then just one quick question. Yeah. How early you will consider vertebroplasty if the patient comes to you in a week's time and he's in terrible pain?
So the clinical scenario, right, at present, initially we were very conservative. As per a standard practice, typical no-no for 4 weeks of conservative trial has to be given. But right now we have been reducing that period. Especially the patient is very demanding, and this patient has to get out of the bed. If this patient is not improving with conservative line of management, the pain is excruciatingly severe, and he's not able to move in bed for a week or so, and he wants to get better immediately. I am right now considering this patient for a percutaneous procedures.
Okay, because a lot of time they say there are chance of leakage of cement migration posterior through the body in the fresh fractures, because we also seen few of them are done very early, and there are complications with early cementing.
Right.
May I ask one question?
Yes, sir.
He said each and every patient biopsy is must. When the biopsy is done at the time of vertebroplasty?
So when we insert the needle inside the fracture, we have to take out the stellate and put the corkscrew syringe and aspirate.
Then send it.
We can send that for cytology.
I think excellent talk. I think only the point I would say that is that we have to look for combinations. So we are treating the patient's fracture, but at the same time, the underlying disease, really somebody needs to treat it aggressively. So as well. So as we are treating kyphoplasty aggressively, I think the major point of my talk was that we should not be neglecting the underlying osteoporosis, which often gets neglected.
Yeah, point noted, Amit. And good topic and coverage on vertebroplasty, Dhiraj. Thank you once again. And we'll move on to Dr. Saumyajeet Basu's cases. Interesting cases in osteoporotic spine. Over to Dr. Basu.
Thanks, Shailesh. Am I visible and audible?
Yes.
So at the outset, I wish to thank the Maharashtra Orthopaedic Association, especially Dr. Gadegone and Dr. Shailesh, for asking me to present a few cases. I think lectures and didactic sessions do not work out in the long run. So let's just discuss a few cases. I think, Shailesh, we have 10 minutes time.
Yes.
So there are 3-4 cases. So tell me if by the third case the time is over,
Yeah.
so that I can stop.
Yes.
And I would really wish to interact with all of the faculty so that we can get an opinion from different perspectives across the world. We are fortunate enough to have people from all aspects of the world. So the first case is a 55-year-old lady, and it's a typical T12 compression fracture with a BMD score of -3 and severe back pain for the last 2 months following a minor domestic fall. And this is the X-ray. And as we will be seeing in most of these patients, we do a supine as well as a standing X-ray. So let us go on with Amit. Amit, do you do only standing X-rays or do you do a supine to compare how much of crushing effect it has?
Yeah, absolutely. I would actually like to get prone X-rays. So if I can, but you know, sometimes patients are in too much pain. I think then I ask them to get prone X-rays, if not standing X-rays.
Regarding this patient, do you always get a CT scan done or you have specific indications?
They all present to the ER and they all come with CT scan. So,
right. So it's a different perspective. So what about Dhiraj?
Sir, just to add to this, I will like to take a standing X-ray and as well as the supine X-ray. I would like to see the anterior opening. I think there should be a huge anterior opening in this patient. And this will help me in deciding if yes or no for vertebral cement augmentation. And CT is always yes for such fractures, just to understand the better anatomy of this fracture, or if there is any breaches around anterior or posterior aspect. Right now, I'm not sure whether there is a posterior breach or no.
Right. So excellent points, Dhiraj. I also personally always do a supine and a standing X-ray. As you can see in this particular patient, the standing X-ray shows immediate collapse and the supine X-ray shows significant opening up. So this is a very good assessment from my point of view regarding whether the fracture is unstable vertically or whether this really would suffice with the vertebroplasty or kyphoplasty or needs additional augmentation by screws, metalwork. And regarding CT scans, you know, these patients, I would not always do a CT scan. For example, a classical vertebral compression fracture without that posterior bulge on the MRI, I might not do it, but on 90% of patients, they would have some bulge or some suspicion of a superior inferior end plate fracture, and that's where CT becomes mandatory. So in this patient, I did a vertebroplasty and a percutaneous screw fixation. Now, Shailesh, would you do a short segment or a long segment? And what would be your plan of management?
I think it's a very good question and very nicely executed, Devan. But most important is the field. There is a lot of disparity between the T-score and the field. At times, you have -2, but the hold is very strong. And at times, you have -1.5 and the hold can be very poor. So I normally prefer to minimum 2 to 3 above and below. Lower, I will prefer 1 less, maybe above 3 and lower 2 minimum at a thoracolumbar junction. Yeah, and if I'm supplementing with vertebroplasty, 2 above, 2 below should be a good construct.
So what about Dr. Kiran or Dr. Wasudeo, Gadegone?
Long segment fixation is always better.
And anybody else?
Is there any stress riser phenomena if you do a strong segment fixation, and then probably you may land up with the stress at the upper zone or lower zone?
I think the long segment based upon the stir images, if there is any posterior ligamentous injury, I think this is OF5. Also, I will see that the patient's fracture is at the thoracolumbar junction. So it's very high risk of further collapse above and below. So I think long segment is pretty much justified. I think the bone density, you said how much was the bone density?
-3.0 in the spine and -2.8 in the femur.
2.8 in the femur. I would have also, obviously keep the cement ready just in case, and prophylactically might have, if I see that, as Shailesh said, if the hold is not poor, I might have cemented that.
So, Tushar, you would be doing the same surgery or be doing it in a different way?
Sir, I would be going for a short segment. A long segment is always desirable, but if I get a good purchase in the vertebroplasty as you have got, I would have got a one level lesser, and I would have done a short segment fixation.
And Dr. Pramod, would you be different on this or?
Sir, can I do?
Yeah,
I echo with whatever has been said. I think that's the way to go.
So I have a little bit of reservations over a period. This surgery was done actually about 10 years back, and over a period of about 8 years back, actually, but over a period of time, I've learned to keep it short because I will show you a case in which I really didn't believe that long segment works. For example, this is a 68-year-old gentleman. It's basically the same profile. This was L1, so junctional fracture. This is an L1 compression fracture. And as you can see that there is a fracture there and there is a compression there. So there you can see that the canal is narrow. And on the MRI also you can see this. So for these patients, I have now shifted over to something like this, in which we do a vertebroplasty through the FNS. And so this technique is that we put in a short segment screw, and all these are FNS, and the void is actually beautifully filled up by pushing in cement through the screws. That's twice the amount. If you look at carefully, this is twice the amount of cement which has been pushed through when through the screw at the affected vertebra. And we've done a prophylactic fixed prophylactic vertebroplasty, one up and one down. Because as you can see, this is a severely -5.8 with a protein electrophoresis which is negative. So let's again go back to Dhiraj. Dhiraj, would you still sort of go for a long segment fixation in these, or do you think this makes sense?
Sir, I'm not fond of too many levels of cementing, sir. Maybe the cost is also effect. Also, I'm worried about the risk of embolism in my patients. Second thing, I will follow what Shailesh said. I will go with the feel of the bone, and I usually try to take bicortical holds with my pedicle screws. So these things have been helping out in my routine practice.
So you feel that if you probe the bone and feel it's very mushy, then it will increase the levels of fixation. Don't you think that increase, the larger your fixation is, that the longer your fixation is, the more is the chance of adjacent segment failure?
Yeah, that might be the case, but using a cement, I am quite worried about using too much of cement, sir.
So cement is a different issue, Dhiraj, but what I'm saying is, as you grow up the age,
right,
your age grows up and your fixation levels comes down. There always is a negative correlation between them. Amit, what would you do? Would it be this one, or would something else?
I appreciate what you've done. So I don't have any. I will be much more traditional, But as I grow wiser, maybe I will change.
Yes, I think the more you see patients coming out with PJF after a long segment fixation, the more you would be shorter. So
ultimate,
Tushar,
you will have to judge the complications, please.
Yes, Dr. Nalawane, can I? Sorry, yeah, please go ahead. So, Dr. Nalawane, can I just sort of ask for an opinion regarding this -5.5? What's your algorithm of ruling out secondary osteoporosis? I mean, I'm extremely worried about all these patients who have less than -4. Are we really looking at some secondary causes of osteoporosis, and how to get about the algorithm?
I missed the age of the patient. What is the age?
She's about 60. He is a 68-year-old gentleman. Very not very old, but this is -5.5.
So usually if it's a male, hypogonadism is one thing which we can consider as the possibility, and testosterone is the possible therapy. Probably you'll have to involve endocrinologist on that. But definitely in all patients, I would consider secondary causes to be ruled out. Simple tests which Dr. Zaveri had mentioned in his talk, like thyroid function tests. And in fact, CKD patients, it's altogether a different issue, but at least those treatable conditions, maybe smoking, alcoholism, this hypo or hyperthyroidism, and glucocorticoid use. Those are at least the commonest causes. But otherwise, other rare disorders, maybe usually it's very rare that you will find any. And
right. So in these patients, I actually have now matured on with the help of my hemato-oncologist colleague, that we should not only do a SPEP, but also in the same breath use a beta-2 microglobulin assay. And in some of these patients, these beta-2 microglobulin is higher than what is the normal range. Normally it's below 2000, say, if it's more than that. So they are, many of these patients are ultimately turning out to be MGUS, monoclonal gammopathy of unknown significance. And
serum protein electrophoresis and urine protein electrophoresis.
No, UPEP and SPEP was normal, sir. So I was just sort of in the last couple of years, I've started doing in addition to that beta-2 microglobulin, because that occasionally picks up MGUS. And these patients, possibly the treatment protocol remains the same, but they are on surveillance by these hemato-oncologists so that in future they can pick up these correctly. So this is a 3.5-year follow-up of this patient, and she was on teriparatide for the first 2 years, and then subsequently started on denosumab. And at 3.5 years, you can see that she's held on well. He has held on well, and there has been no further collapse. And the BMD is now minus 2.9, and still now he is doing okay. It's now about 4 years. Let's see how long he. As I really believe that osteoporosis is more of a systemic illness than a local illness. Let's see how he does. So the last case, or possibly we can do another if time permits. This is one of the 75-year-old ladies, D12 birth fractures minus 2.8 DEXA. And this is what you can see, supine and standing x-rays. Again, pushing forwards the point that standing x-rays actually show you how much of kyphosis is happening there, the need for anterior augmentation, anterior reconstruction, and how much of the deformity is actually picking up. And in most of these patients, they are not sagittally off balance, in spite of the fact that there is about a 60-degree kyphosis in the thoracolumbar area. She's not out of balance because she compensates with the thoracic hypokyphosis and lumbar hyperlordosis. So based on this, so what would be your treatment? Before that, let us have a very small discussion regarding what is this an osteoporotic compression fracture? Is it a burst fracture in osteoporosis? In my terminology, I would really try to call it as a burst fracture in osteoporotic patient. So what about Shailesh and possibly Dr. Gadegone?
Yeah, Dr. Basu, I think it is definitely a burst fracture in osteoporosis, but we need to rule out whether there is any other cause, because the remaining vertebral body looks reasonably okay. DEXA scan may not be that bad.
There is one more compression at the above level. You can see here.
Yeah, that's an probably old fracture. And we need to rule out whether it is any other myeloma or metastasis. Anything is there in this patient. So we need to not miss blood investigations as a paramount basic investigation, like hemoglobin, calcium, alkaline phosphatase, some markers we should do. But essentially, if I look at this, I probably will prefer to consider this as a junctional level, and I will consider a long segment decompression fusion, basically.
So you would do a decompression also? Or
if there is no neurological deficit, I am not sure how much is.
They have very soft signs, Shailesh, just a little bit of hyperreflexia.
Okay, okay. You can just stabilize this in situ and splinter it long. That is what will be my plan. Above 3 levels, above 2 below. That should be good enough. The above fracture looks like an old fracture. We can definitely use that also.
So no anterior reconstruction.
You can definitely consider anterior reconstruction in this particular case because there is a significant collapse. If you give anterior reconstruction, that really adds up to the stability and sagittal parameters.
Right. So, Amit,
yeah, I completely agree. I think I will go a few points. I think first thing, I think supine X-rays. Instead of supine X-ray, I sometimes just look at the MRI and CT scan. It gives a lot of information too. That's done supine too. Also, I think this patient needs to be looked at a different angle. Maybe there's something going on. If the trauma is not significant, why did she fracture like that? Maybe need to look for tumor point of view. But to reconstruct, I think 3 segment up. If she has severe, osteoporosis on DEXA scan and TBS score looks pretty bad. Her fat signal in the MRI looks pretty high. I think I'm going to go at least 3 segment up, 2 segment down. I will try to either do 2 things, either do anterior reconstruction. I will cement the inferior end plate and also put a cage there, or I can do a spine shortening procedure. I can take the pedicle out and just do a shortening procedure like a VCR and just go ahead and get it done. It's at
what will you do, Amit? You have options, but I just want to know.
I will basically do a shortening procedure. That would be quick and easy.
That means an open procedure. It's an open surgery.
Yes, open surgery.
And Tushar?
Sir, I would go 2 level above, 2 level below. I will not do any anterior reconstruction. I will try to get hold in the fractured pedicle as well. And I consider the aging another part. I would just kind of brace it. I will provide kind of internal bracing for this fracture. And no.
Pramod? Dhiraj?
Sir, I will like to, just to add, I will like to go 2 level up and down. I will like to augment the above fractured vertebra with a cement just to prevent further collapse there. A posterior decompression intra-body bone grafting will be something I like to do in this case because on CT it looks to be acceptable kyphosis against the standing view. So I like to pack with the intra-body bone grafting and 2 level up and down.
Just to one point for Dhiraj. Probably when there is a retropulsion, normally I personally don't prefer to put a cement in this.
I'm going for autologous local bone graft.
Okay.
No cement.
You have any other suggestions?
Yes. So that's a unique case where you have both intravertebral as well as intervertebral instability. The pseudo-orthotic cleft suggests that there is an intravertebral, whereas the kyphosis and the angular change at the thoracolumbar junction suggests an intervertebral. So I think what all options have been discussed, all applies here. In situ fusion with minimal undercorrection of the deformity would. So I will do that. In my hands, I will prefer doing that. But a good support anterior with cementation and fixation is also an option.
So this is what we did. I was, this 10-15 years back when all these MIS systems and this MIS cement augmentation is not available. By the way, I did my spine fellowship in 2002. And in that point in time, there was nothing called a percutaneous screws, nothing called a kyphoplasty. So anyway, these are techniques which has come down, and this has really reduced the morbidity of open surgery. So I did this 3 up, 2 down, and a good cement augmentation. I think I did a reasonably good job, and she was doing well at subsequent follow-up. She's a lady, in spite of the fact that she lives 200 kilometers away, regularly used to come for follow-ups with BMTs and X-rays. And at subsequent follow-ups, she did have a BJK with the proximal screws cutting out as was expected. And but she was absolutely asymptomatic, managing her own household chores. Till a point in time, at 5 years follow-up, she comes with a sudden severe pain after a jerk, and the BJK remains as it is, and there is an additional fracture there, which is a typical cleft with a Kimball's lesion there, and for a month, 1.5 months, she was symptomatic, and that was her BMD. Right now, it's not too bad, with minus 1.6, and it was minus 1.7 initially. It's now minus 1.6 in the lumbar spine, and the femur pretty remain the same. So at this point in time, what intervention would you do?
Dr. Basu, please proceed as we are short of time.
Yeah, this is the last case. Yeah. So
Just
any
to complete,
intervention?
I will like to go one level above above the fracture vertebra, and over that I will another level I will like to add a sublaminar wire and cement the fracture vertebra. Sir.
I would like to conserve this patient and give a good medical trial conservative before doing any operation.
She was significantly painful at 2 months follow-up. She wanted something else.
Vertebroplasty.
So what I did was I just did a unipedicular vertebroplasty, and that seemed to work out very well. Her pain came down. But 2.5 months down the line, she came back with spasticity, paraparesis, and then I actually did a repeat MRI, and this was the cause. They had a sensory level of T8. So, Amit, at this point in time, how would you proceed?
The whole thing, complete maybe T4 all the way down, decompression, proper deformity correction, everything.
So, tips about PJK? I did go up. I did decompress this area, and this time I had to open it up because I needed to connect these. I had to connect a long rod into this, and so I had to open it up this time. And this is what we did. And tips about PJK?
Put a hook in the transverse process, more oblique screw, curve more into kyphosis.
So I had a very long word with Dr. Sengupta on this. His beautiful system of putting in the screws angularly into very caudally. And the only issue is that if you really have to put it in caudally in anything above T4, you have to actually crush the joint above. That is very difficult to preserve if it's an anatomical pedicle screw placement with the entry point very, very near to the facet joint which you're trying to spare. And that means a facet joint violation may be on the cards. But he does give an additional hook upstairs, so which might solve a part of this issue. We are on a prospective trial of this sublaminar wires to avoid PJK. Let's see how it does. So till the first few months, I mean, it's now about 2 years that we're trying this technique. None of them have failed, but time will only tell. So I think we will end with this last case. In this same case, it's a similar fracture. But this time, if you look at the coronal section, there was a suspicion her CRP was normal. And this time we did the same thing, but we took a biopsy. And this biopsy turned out to be gene expert positive. And so she had teriparatide along with histopathological, along with anti-tubercular drugs. And that was her at 1 year follow-up. Thanks. I think I've just been sticking to time. Thank you. I'm open to any
sir, one quick question. So how you prevent the posterior ligamentous complex? How you to preserve that while inserting sublaminar wire at the proximal level?
No, you don't. You don't. That is the main disadvantage of using the. I just unshare. Yeah. So that is the one of the main disadvantages which has been quoted for sublaminar wires versus Marcelin tapes. Marcelin tapes are not available in our country, but the proponents of Marcelin tape say that they can actually preserve the midline structures much better, which you really cannot. I mean, possibly technically speaking, you can, but that's a very major hurdle, and you spend a lot of time in putting in the wires.
Also, they say the soft landing, the third case which you showed, the rods were quite straight at that dorsal level. So if you do a kyphosis at that level, which is going towards the body, that is very, very important. The angulation of the top rod is also one of the important factors for a PJK.
Actually,
that's a new thing.
No, Shailesh, I'll just put in a technical tip here. If you over kyphose, whenever the patient is on a prone, the thoracic kyphosis is lost. Especially in these patients, you have a lost thoracic kyphosis. So the thoracic kyphosis becomes flatter. Now you over contour your rods. And if the rods are sitting proud over the screws, then you have to pull each and every one of the screws into the rod to build up the kyphosis, which again is not good for
only the topmost part of the rod. That's what.
The topmost part, you always do an inside to contouring so that they sit into the tulip rather than the tulip coming into this rod. That's always there. But to maintain the thoracic kyphosis is very difficult and it's technically quite challenging, at least in my hands.
One just question, Dr. Basu. Now, in today's time, if you do the same case with that big opening, will you go anterior? How differently you will do it?
Come again, Amit. Come again.
The third case that you showed.
Yeah.
If you do it today, how differently you will do it?
No, this was a 5-6 years old case. So nowadays that's why I do not do long fuses. I do a short one. So I think the PJK happened because the fixation was too long.
Not this one, not the last one. The one before that, the one with the open that you did a 3 level above and 2 level below.
That's what I'm saying.
Yeah.
Today I would be just doing a 3 level fusion, 6 screws. 6 screws, 6 fenestrated screws rather than using 10 screws. I did use 10 screws there without any screw in the cemented vertebra. I routinely put in screws in the cemented vertebra along with which are FNS screws along with the cement augmentation. Twice the volume of cement, you can easily put it in. So I think that becomes a rock solid small construct and doesn't allow a lot of collapse.
Now we have last 2 presentations and a literature we'll proceed with. Thank you, Dr. Basu, for a wonderful case.
Thank you. With your permission, can I leave, Dr. Gadegone?
I want to.
Yeah, no, Dhiraj, we have to move on to the next because we are really running short of time.
Thank you.
And over to Dr. Tushar, who will be talking on a very interesting case, and we all are welcome for various inputs. Yes, Dr. Tushar.
Thank you. Is my screen visible, Shailesh?
Yes.
Okay, thank you, Shailesh and Maharashtra Orthopaedic Association for giving me the opportunity. And we have learned about the tips, tricks, and what are about the vertebroplasty. Now I'm going to discuss what can go wrong in these cases, and one should be aware of the complications as well. So we had a 58-year-old female who was a known case of COPD and hypertensive. She was already on steroids, and she sustained a trivial fall, which was followed by the severe pain in the mid-back. If you can see, the X-ray showed a osteoporotic fracture in the D11 region, which was clearly visible. And we started her on a medical management and gave a good trial of conservative treatment. And she continued with the treatment. However, the pain was persistent in spite of adequate trial of 6 to 8 weeks of conservative treatment. So the MRI, which was done in the latter, like in the 7th week, showed some amount of bone marrow edema, again the waist shape end plate fracture, but there was no cord compression, nor there was any other pathology that we were suspecting. So we decided to do percutaneous vertebroplasty. The patient, when she was given a prone position, she became quite uncomfortable because of her pre-existing respiratory compromise. So anesthetic decided against the intravenous sedation and they gave a GA. We use a Medtronic Kyphon V vertebroplasty kit with a 11G needle, and we pass the cement percutaneously. As soon as we injected around 5 cc of the cement from the right side, we noted that the cement was leaking on the back of the D11 and D12 vertebral body, and that was noted going down as well as up. So we immediately, as the patient was already under GA and in a prone position, we immediately took a decision of exploration, and we did a laminectomy, which was from D10 to D12. And we could take out the cement which was there in the front part of the apical sac. However, we noted more cement in the medial part of the medial to the medial pedicle wall of the D11 vertebra. So the more cement was coming from the medial part, that indicating that there was a perforation of the medial pedicle wall, and which was primarily responsible for the breach. So whatever the cement which was there in the front part, we took out with the rongers and the drill, and the remaining cement which was in the gutter and the foraminal region, we left it. While taking out the cement, there was also a tear which was around the D11 vertebral root, because we had to take out that facet as well to do a thorough decompression from the side, because we can't retract much cord in this particular region. And since we had compromised the posterior bony structure, so we decided to do a fusion, short segment fusion with a purchase in the vertebral body and a posterolateral fusion. Luckily, the patient woke up with a good normal neurology and had an uneventful follow-up, except for the transient right-sided numbness because of that, the nerve root handling which was there on the D11 side. So the post-operatively, the back pain improved significantly. This was the fixation that we did, and this is a 3.5-year follow-up of the same patient. So the basic thing about this complication, and we'll take an opinion of the faculty as well, but some few basic point that the listener should know, that the asymptomatic cement extravasation is very common, and it is observed up to 70% of the patients. And if you do a post-procedure CT, which we don't routinely recommend, it is seen up to 90% of the patient. What you do see is the epidural leakage, which is also a very common thing, but it goes undetected because it's not significant. You may get a neurological injury if you get a cement extravasation in the canal, and there are two possible mechanisms. Not only just a spinal stenosis because of mechanical compression of the thecal sac that the deficit can occur, but it's also the exothermic reaction of the cement, which can inflict a significant damage because the cement is in the anterior part near the pyramidal tracts. Again, regarding the anesthesia, it's very important because it's a short procedure. We can get away by doing it in local anesthesia, which is also advantage because you get a real-time feedback from the patient with respect to the radiculopathy, or for that matter, if there is any neurological compromise, you can do a real-time feedback testing. There are a lot of patterns of the cement leakage which have been described, but these are the three leakage patterns that one should know. The B stands for the basivertebral vein, which when you inject the cement in the mid part of the vertebral body, the cement accumulates and the basivertebral vein carries it in the epidural venous plexus, and you get a cement accumulation in the spinal canal. That's called the B variety. The S variety is when the cement gets carried by the segmental vein, then you can see it around the vertebral body, and this can be dangerous. We'll see in a next slide. And the cortical C bridge, which we had in our case, where the cement can go exactly in the spinal canal. It may go in the disc space. It may go into the outside prevertebral and paravertebral region. One has to also understand, if you get a cement in the disc space, it's a hardened ball, so it can cause an adjacent vertebral body fracture. So one has to be careful about it. These are the leakage pattern that we just saw. If you get a B pattern, the basivertebral vein carries in the epidural venous plexus, and you get a leak like this. If this is a S pattern, where the segmental vein carries it along, and this is the segmental vein which is carrying the cement, this can lead to disastrous complication if you get a pulmonary embolism, as we had the faculty describing it. Again, one has to understand the osteoporotic fractures may have a cleft or may not have a cleft. It is not necessary that you'll get always a cleft in a pseudoarthrosis. And cement leakage, depending on the cleft, was described. Those patients who had a cleft can accumulate more cement, so they had a less chances of leakage into the epidural venous plexus, whereas those who don't have a cleft have a higher chance in the leakage into venous plexus, and vice versa. Those who have a cleft have a compromised supra-end plate integrity, so there's a very higher chance that you will get an extrusion or extravasation of the cement into this space. So one has to understand that these patients with a cleft, you can accumulate slightly more cement than those without the cleft. The fluoroscopy during the injection process kind of expands the wall, which drives the surgeon to push more cement, and this is the prominent reason that you get the cement extravasation. So there are various locations where the cement can go down. It can go down to end plate or disc, which is one of the commonest region where the cement get extravasation. The paravertebral is second most. The epidural is next. The prevertebral and pulmonary are also known. If you can think there's an add up, this will not add up to 100%, because in a one patient you can get a more than 2 patterns of the cement leakage. And we will also, at the end of this talk, I'll ask for the optimal timing when you see any leakage. When would you go in to do, or would you go in? That also is quite variable in the literature, and there's a lot of variability. This is the same segmental vein extravasation. Please understand, this segmental vein doesn't, the cement doesn't get collected only here, but it goes in the pulmonary circulation. These patients get respiratory issues. And for time being, you can very well salvage this patient with oxygen saturation, but please understand that they have very high likelihood of getting an irreversible pulmonary hypertension and a cardiac failure thereafter. In fact, these segmental vein cement embolia are known to go in the cardiac circulation, and that hardened ball are known to cause a myocardial perforation also, and there are case reports mentioning that as well. So one has to understand that if not performed properly, this procedure can be very disastrous. The second, we should also know at the end of this that what are the probable reasons for this leakage and how one can avoid during doing this particular process. So the most common reason is excessive volume of cement. Dhiraj described that approximately 4 ml is the one which you should try. So there are a lot of literature which mention that approximately up to 4 ml in a thoracic vertebra and approximately in a 5 ml in a lumbar vertebra. But please understand, there is no cutoff per se. It's the feel, the adequacy on a fluoroscopy that one has to decide. It's not that you inject more cement, so you will get better pain relief. Please don't get into that misunderstanding. So it's an adequate volume. In fact, more cement can be very counterproductive. Second, when you are injecting the cement, usually when the cement starts coming to the posterior 1/4 of body, you stop cementing. That's a danger no-no zone. If the cement starts coming behind, it can endanger the neurology as well. Second point is most important is the excessive pressure. So please try to give an intermittent release in the pressure. The most common problem that we see is that at the end of the procedure, when you are injecting the cement, the front cement gets slightly harder and you try to give a more pressure, and that is when the cement shoots out and it causes a leakage in the spinal canal. As we have seen in the case which I presented, the breach in the medial pedicle wall is very common and one should be very careful about it. The improper needle position is the second point. Commonly the needle should be in the anterior 1/3 and middle 1/3 of the vertebral body. It's better to have a bipedical approach as Dr. Amit suggested, but the chances of leakage are more as compared to unilateral, but it has its own pros and cons. In a bipedical, it's not technically demanding. You don't need to converge too much, but if you are doing a unilateral approach, you want a cement in the opposite half also, so you need to converge. So it becomes technically demanding. And if you have a pedicle which are straight on, it becomes difficult to do. Posterior cortical disruption is always issue, and we have discussed that in a CT scan in acute or a subacute fracture. It's important to evaluate the posterior body wall so that we can plan accordingly. It's a low viscous cement is always a risk because it has a tendency to run off and it can run off. So it's very important that you start injecting the cement when it becomes paste-like and not when it is a liquid. And if there are certain tips and tricks which I would like to highlight, if you see while injecting the cement that it is going into the vein, then you stop for some time. It is usually known to cast the vein so that it can prevent the further embolization. So you give it time. It's okay if your cement goes west, you can carry out another packet, but you stop that time, you wait the vein to get casted, and then you can carry it forward or you can abandon depending on the condition. Similarly, if you see the cement extravasation which is happening outside the vertebral body, then please stop temporarily so that you can avoid going further into disc space or a pre or paravertebral space. The last point is that when you are withdrawing the needle, please use a plunger so that you don't carry that cement tract in the pedicle and in the subcutaneous manner because it is painful for the patient. So it's very important that you put a plunger. And we discussed that you get a medial pedicle breach. If it's not significant, you keep the needle in that particular position and you try to attempt from the opposite pedicle. When you are attempting from the opposite pedicle, don't remove the pedicle, the needle when you are inserting in the one pedicle. So both pedicle needles should be there. So there should not be any extravasation to the medial pedicle breach. It will act as a spacer or blocker for your cement extravasation. So please keep that needle as it is and then try to inject from the opposite side. These basic tips can prevent a significant catastrophe. So I will keep my presentation very brief. The take-home message for the listeners is that asymptomatic leakage is very common and what does not need to do intervention for each and every leakage. It's very important that you have a high vigilance towards the leakage. And how do we keep that? Moment you start injecting the cement in the lateral fluoroscopy view, please have a continuous monitoring of the leakage by doing a multiple shots or a fluoro, so that the moment the cement starts leaking out, because there'll be some real-time difference with respect to the visualization and the cement extravasation, and you should be quick enough to know whether the cement is going in the canal. You have to do thorough pre-op workup. As we have seen, the posterior vertebral body wall integrity is very important. The accurate needle placement cannot be overemphasized. If your needle is in the wrong position, you will get all sorts of complication and all sorts of extravasation. So one has to be very particular before placing the needle and injecting the cement. And these 3 E's should be avoided. Avoid excess pressure, avoid excess volume. Don't think the volume or pressure will give you a better result, and avoid excess fluidity of the cement so that it should be in a paste-like when you are injecting it. And in case, if you see a significant leakage in the canal, please assess the neurology, especially because we do this procedure in the local anesthesia. You assess the amount of the extravasation which you can see on a fluoroscopy, guess it. And if needed, there's a lot of controversy in the literature when to go in if you see a cement leakage which is significant, but most of the literature inclined towards the earlier intervention. Thank you for your patient listening. Yeah, Shailesh.
Yeah, Tushar, wonderful talk, and it's not very easy to manage when things happen on table like this, and you really executed it very well. So I must compliment you and your team for taking appropriate decisions. Ultimately, that is what is important. And we have seen few cases where the cement is leaked and patients are transferred. I have myself operated one patient with monoplegia, And when the time is gone, it's probably difficult for the nerve to recover. That's also very, very important.
Shailesh, I have one question to ask. If you get a leakage, what is the timing? Do you go for a post-operative CT and then you take an opinion, or how do you proceed about it?
I normally am a very conservative surgeon. I use very, very small amount of cement. My cement injection is 1.5 to 2 centimeter to this is cc, because I think it's like a closed container, and thermocoagulation for nerve ending is the thing which gives pain relief. It's not the amount of cement. Therefore, in day one, we use very small amount. The chances of us to have leakage is very, very less, and I try to prefer it to put. But still, if there is a leakage and I'm seeing it on table, that's going to be a difficult situation because I really don't know the neurology. Though we do it in sedation and local, I probably will prefer to do an immediate CT of the patient first.
Right.
Yeah, I have a question. Yeah,
Sir, I have a question for you, and Shailesh and Amit can add to this. What is the right time when you start injecting the cement? When you feel it is safer to inject the cement?
This is the right thing, what I feel. It's important because every operation theater has a different air conditioning system and the softness of the cement. So always keep checking when the cement starts becoming semi-solid and little harder. That is the right time. The early you do, you will have a problem, and the more you are trying to put, you will have a problem. That's what I feel. If you are going slow and steady, you will probably not encounter these problems.
Right.
Dhiraj, I think I have nothing more to add, as Shailesh has already pointed out. These are the important points. The other thing which I want to bring down the attention of the faculty is the size of the needle, because the literature says that there's a 11G and 13G. Since Dhiraj has mentioned vertebroplasty, do you feel that you should try to get a 13G in a thoracic spine and 11G in a lumbar? Is there any thing that you follow, Dhiraj?
No, right now I'm going 11G for all of my cases. But I wasn't aware that 13 with 13G also it can be done. Never used 13G in my practice.
I will just like to add how I do is that I take one ball of nice warm saline. Then I do usually ask them two syringes or 2 cannulas to be put inside there, so it sets pretty quickly.
Right.
So it sets pretty quickly, and there is other cement which is not, it's still cold. So I use that cement, and I am very, very slow. As I said, Shailesh, I'm very, very conservative. Very rarely I do more than 1.5 ml per site. Very rarely. It's very rare. And the most important thing is having 2 C-arms. And the other thing is that you have to make a cavity. I think I make sure that even the pressure of the kyphoplasty balloon, I keep it very low. I go very slow with that, so that it creates a nice cavity. It doesn't pop out through the end plate. So once that cavity is nicely created, I start from the very distal end, put a little bit, and also it is very important to understand to back out. So there are few systems that there is one system with a syringe and there is a tube attached to it, a small caliber tube. What happens is that when you turn that, a huge amount of cement goes in there. And but the advantage is that when you pull out, it also comes back quickly. But if you're using cannulas like Medtronic system has or something, it's difficult to withdraw it. So there are pros and cons about it. Usually it's recommended that you use a big syringe and then a small mouth nozzle coming out of it, so that if you think that something is going out, you can just go ahead and twist it back and it will come out. But like 2 C-arms are really non-dispensable. I use biplanar all the time. They are both on fluoro, and I think each cannula is 1.2 cc. I know I'm going to use 1.2 cc and then I'm going to stop.
Shailesh, before you start your talk, I have one more question for you. If you get a medial pedicle bridge during the procedure, so how do you go about? Do you abandon or you try to cannulate from the opposite side?
No, I think it's a very important question, because you can't go anterior when there is a bridge. I probably will stop it. I will put something there like a gel wax or something, and I will go from the opposite side.
Sir, but how you will pick up a medial breach?
Fluoroscopy, right? Fluoroscopy.
Yeah, but fluoroscopic, you are going very slowly with a fluoroscopic guidance.
So if your needle, the same thing that we see in MIS if you are not in the body and if you're still crossing the midline, then you probably had done a bridge. And then if you try to correct this kind of issue, the literature says the cortical leakage is due to two reasons: either your medial pedicle bridge or the posterior wall disruption. So I think there's the whole extravasation which is under the control of surgeon occurs due to these two factors. So fluoroscopy is the way we find out.
Yeah, thank you, Tushar, for a wonderful, interesting case. I think in want of time, I will just run through my presentation without much discussion, and we can discuss at the end because we have Dr. Pramod to talk about current literature before we complete. Quickly, we'll go on the cases. D12 fracture, 1.5 years, and this is the surgery. Again, the patient comes back with back pain, difficulty to stand for a long time, and this was a MIS done elsewhere. These are the challenging ones, and again, normally what we feel junctional level short segment fusions probably are the day one failures in my opinion, because the amount of fixation, the way it was done, a lot of things went wrong in this particular patient, and I think we'll discuss subsequently. And this is what was done. The revision strategy was splinter it, do a good sagittal planning for sagittal parameters and long fixation, because these are the osteoporotic bones. You try to stop at shorter and you will have a problem. Again, most important, I prefer nowadays longer screws to the second cortex, and dual core screws are really good. HA coated screws are also good, and cement augmented. I personally prefer either HA coated or dual core in our practice. This is a 67-year-old practitioner. He's a physician. He was operated elsewhere 12, 13 years back, and he comes to us with this proximal junctional problem. He took opinions all over. He went out of India also to take opinions. As he was really scared. There was significant narrowing and compression at the junction level in the MR, if you see, and though he was not myelopathic, but he was having early signs of myelopathy. And again, it was really a challenge because I think the pincer was giving him that compression. We did again a long segment. We used the O-arm, which gave us a very good long screws construct these days. And these are the screws which are dual core. And the D of the screw is important. When we see in axials, you really can go up to the anterior cortex in convergence. That's the beauty of using the long construct. Again, an interesting case. These are the cases I'm just showing because we all see these cases in our routine practice. And again, there are the nightmares and challenges at times. Demanding CEO of a company operated elsewhere out of India comes to us with persistent pain at that screw, which was loosened up, and his T-score was minus 2.9. And we had no option. We used the DBM to accentuate the fusion and use the long construct to fix it. And now it is nearly 3 years he's doing so far. We started on anti-osteoporotic management for him. Again, this is an interesting thing which we have used in a few of our cases. Sublaminar wires. This was a very frail lady, diabetic, hypertensive. She was operated elsewhere. If you see the skin, it's very close, and this was constantly pricking to her back, and it was pointing out. She couldn't lie on her back, and they were really. I gave her a pain block. I sent them home again, and again she was coming. Then I planned for revising this as there was severe pain because the screw was loosening and there was lucency. We planned for a sublaminar wire and fixed it. And this is almost eight years back because she was very frail and the skin was very, very close to the tulip of the previous implant. I did this, and luckily it's now 8-9 years. She's holding on well, and she comes once a year to just follow up. So these are the things which we normally prefer to use: the sublaminar wire, the hooks, the soft ending for the porotic screws. And again, when we talk about the calcium phosphate cement or the laminar hooks, which probably helps, but there is no great literature in support of this. our learnings in this is probably when you have such kind of a fracture, osteoporotic minus 4.1 and deformity. I personally am a very conservative surgeon. As I said, I prefer a long construct with a long, with a two cortices purchased, and normally we really can get very good outcomes. And this is what we routinely prefer. When there is a deformity, don't stop short, because there are high chances of the axial loadings problems which can really come across in this kind of patients. Certain, again, interesting 1-2 cases I will just show. This is a case which was operated, and post fixation, patient went home, comes back, and at 1-2 year follow-up, 1 year follow-up, he shows this adjacent segment. And probably what went wrong is not that biology, it's probably the bone quality. The osteoporosis is leading the way now, and we really need long fixations in such patients. Important is augmentation of patients, and certain other cases where we see this patient was with multiple myeloma, which was diagnosed after 1 year. He presented to us with Koda equina. He was operated for a lumbar small incision discectomy elsewhere. When he came to us, he had all these multiple fractures, and he was treated extensively for osteoporosis. And this is what was his condition. And he was flown from almost 800 kilometers to us. If you see, there was a large compression at lumbosacral region. He was having bladder symptoms. We did decompression and stabilization for this. The biopsy revealed it's multiple myeloma. The blood parameters also revealed multiple myeloma, and this patient was subsequently treated by the oncohematologist, and he's doing fine. Now it is almost 2 to 3 year follow-up. I will just show one quick case of, again, such a tumor. 49-year-old mother of a budding orthopedic surgeon, CA cervix and metastasis, lower limb weakness, and this is what was the fracture. There was osteoporosis with previous history of METs, and we had no option as she was deteriorating. We did decompression and fusion. We sent this tissue for histopath. It did not reveal any metastasis, and we did an anterior reconstruction in this particular case. And these are the routine cases which we see. Patient comes, operated 3-4 years back, fall in bathroom, adjacent segment level. You can do a vertebroplasty. This lady was a very, very morbidly obese. Therefore, we planned for an extension of fusion in this particular case. And there are various interesting cases where we have to really plan. This was lumbar decompression, minus 3.3 DEXA score. This is the dual core. I'm just showing it for the interest of orthopedic surgeons who are doing spine practice. This is really a good screw which can really give a good pull-out strength, and we can have better chances of having less failures with this dual core screws. So I think the list will be unending. I would like to thank everyone for the wonderful opportunity, and we can proceed with some questions. Yes, Dhiraj, Amit.
Wow.
Wonderful cases, Zabardast. And most of the cases you have done good job, especially the bicortical long screws, what you have been saying, and long construct for osteoporotic unstable fractures. I agree with that.
I have one question. So what do you think? It doesn't seem like you like cemented screws. Is there an issue with cemented screws? And
No, cemented screws. I have used cemented screws, but nowadays these dual core screws are really good, and HA coated screws are also holding on very well. There is no personal bias towards. You can definitely use cemented screws.
And other question is, what do you prefer? You prefer the the normal parallel to superior end plate trajectory or the anatomical trajectory angle down?
No, I think I prefer the standard trajectory, not the angle down. Angle down I use in deformity a lot. But in osteoporotic, I prefer a standard end plate trajectory. And it's important to hold on the end plate. That's very, very useful. You get a reasonably solid hold when you go close to the anterior superior end plates.
Yeah, very nice presentation. I have one question regarding the rod contouring, which we are discussing with Dr. Basu as well. And I see most of your cases, the rod contouring is very nicely done, and there's a slightly over contouring. So are you biased towards the kind of over contouring, considering that there's always a possibility of PJK and other things?
No, I think what we consider is under contouring is a problem. That's what I personally feel. Therefore, at least anatomical contouring at that place where you will not have a screw pull out on table. At times in osteoporotic, you put the screws and when you are tightening, it starts coming out. So that's something which is a strict no-no. And sometimes you feel, oh, it's already 3 hours now, I just accept it. I don't want to do that. I want every screw to be holding well, and rather than advancing a level because it is loosened out, it's better to contour at day one. That's the strategy. Probably, yes.
And do you know, there is an increased blood loss in osteoporotic spine when you are doing this long instrument, because when we tap immediately the blood comes up. So are there any tips that you do for kind of minimizing that blood loss?
No, I think, yes, I mean, some patients do have blood loss. I immediately use a bone wax so that I don't have a problem. And then immediately we put the screws. When you confirm it, you just go ahead. You can do a free hand. We used to do free hand for a longer time with C-arm, but nowadays we use O-arm routinely. This is an old case of 4-5 years. So this was a free hand with, yeah.
Shailesh,
Yeah.
I'm seeing you have been using more of an open fixation technique, and I am also doing the same in my practice. But I'm seeing an increasing trend of non-fusion MIS fixation. And I'm just worried about this kind of fixation in osteoporotic spine. So what's your say on this?
I completely agree, Dhiraj. It's a very important question. And somehow I feel that is going to come the MIS way. I am still doing more of a standard time-tested answers for this problem, It's very lucrative and appealing for me, but my experience is limited to these kind of surgeries where we have reasonably given good results over the long period now. So therefore, I am yet to venture. We have done a couple of cases of short segment with MIS, but we are doing most of the cases in a traditional way.
I would like to have your 5 to 10 points or what you do specifically when you put the screws for osteoporotic spine. How do you do it differently? Do you tap or don't tap? Do you violate the initial entry point?
It's a very, very important and valid point. I normally personally do a standard marking, and tapping is not really my practice. I just use a first and second starter probe, and then I go with the screw. That's it. Tapping somehow is you tap and you don't get sometimes a good hold. And important is the anterior cortex. In my practice and angulations, if you have a very good convergence and angulation, you can get a longer screw. If you see most of the cases which have failed are with shorter constructs. In any of the
lateral entry and more angulation.
Yeah, more angulation. That's the most lateral entry and more angulation towards the center part of the D. What we think is laterally we are trying to go straight, and a lot of time in osteoporotic failed cases, you see the angulation is inaccurate. The convergence and the angle of inclination is very, very important when you are putting. So if it is good, you will have a very good hold.
And measure to the perfection so that we can get bicortical holds.
Yeah.
So one question from my side. Shailesh sir, you have a paper which has been published in the Interdisciplinary Neurosurgery Journal, which is an index journal, of osteoporotic screws. Those are the precious pedicles, and in that you have used O-arm. So how do you feel that compared to, you have seen the both sides of navigation, the hand navigation versus a neuro navigation? I think, how do you feel the O-arm has helped you in doing all these cases?
Yeah, thank you, Prabhu. It's an excellent question. Now we are using O-arm for nearly 3 years. And this paper which we published last year was around 200 screws with 99.60% accuracy of the screw in osteoporotic pedicles, which probably was not as high as what we are using. In the past, we have used it, but a lot of time we have gone slightly lateral, slightly away from the pedicle, or slightly superior, something like that. But OARM is giving you almost near 100% accuracy of placing the screws and the convergence. I think again and again I'm emphasizing the convergence is the key, where you are getting a longer screw length. The minute you are going lateral, you feel you are going anterior when you are doing it. Therefore, you are more convergence, you get a beautiful longer screw, and you can reach up to the anterior cortex. And OARM is, the navigation is helping us with that, for sure.
Do you use a drill to put the screw, or like a power thing? Power?
No power instrument.
No.
With, at least in osteoporotic, no power instrument. Okay, thank you everyone for great inputs, and we will proceed with our last but the most important demystifying topic by Dr. Pramod Bilare, and let's know what the literature is talking about. Pramod, over to you. Please share.
Yeah, yes. Is my screen visible?
Yes.
Yes. So I think a very important topic. I think the big guns have already fired. They have already given the tips and tricks, the pearls of wisdom, how to approach a osteoporotic spine. I think my job is a relatively smaller job. I think I'll just summarize what has been told so beautifully in the last 1.5 hours or so. So this is what the WHO statistics looks like, right? So if you see WHO 1 in 5 will have osteoporosis. I have selected this 5. I have selected the president-elect, Dr. Basu. So it doesn't spare anyone. It can get to the bestest person on this planet. It can get a person who is right now sitting in US, or it can get a person who is non-orthopedic surgeon, is a rheumatologist to start with. It can get through our convener itself, or it can get through a mere mortal like me. So who that person will be, we don't know. But yes, it somehow, sometime it's gonna get us, and definitely for sure. So these has been broadly been indicated. What are the indications when you are being treating osteoporotic spine? So the intractable instability pain is the one. The neurological deficit has been largely been debated and been discussed. The deformity at times is the indication for surgery. And at times an osteoporosis can be an associated condition. You might be treating tuberculosis in a 70-year-old, but then the osteoporosis is something you have to deal with. The reasons for these failures, or the so-called losses in osteoporotic spine, is usually the patient selection. If you don't select your patient well, you're bound to fail. If you don't take up the treatment or the selection technique well, you are bound to fail. See, to start with, osteoporosis, you are always dealing a lost battle, right? So poor bone quality will lead to a poor purchase. And at times you do the bestest of the thing in your hand. You have used the bestest of the neuro navigation. You have used OARM. You have got a bicortical purchase. You have done cementing, everything. But still you land up in problem. At times it is just the destiny. You cannot really blame the destiny. So at times, what is the cement augmentation looks like? What has changed over the period of time? Since the 2007, where there was a big debate between the Kalmes and the Bushbinder trial, which revolutionized the thinking of vertebroplasty, compared it to the sham procedure, to the present Vertos 4 trial, which is the latest in 2018, published in the BMJ, the High Impact Journal, which has again compared and come down to a conclusion that the vertebroplasty is nothing but a sham procedure. But yes, I would say the tilting, or there is still bias towards the vertebroplasty. We have got 2 lectures in our series right now talking about the vertebroplasty, the technique, the complications. So here we are, as a surgeon, biased towards the vertebroplasty or the cement augmentation technique. I think Dr. Amit has talked about the different modalities of kyphoplasty. The vesselplasty is a new kid on the block. here the patient selection is important. Which patients really tend to do or tend to respond best to your treatment is usually a single or only a couple of levels of vertebroplasty or cement augmentation, where the cause of pain is to the instability or the affected vertebrae, the focal pain and the tenderness corresponding level on the MRI. Fracture which is less than 2 months duration, or the fracture which is limiting the activity, are the ones who really do well. Less likely to respond is the older ones, where the causes of back pain can be multiple, like disc herniation, spinal stenosis, facetous, sacroiliac joint disease. Very difficult to really rule out these cases and really pin down what is the cause. In these cases, you tend to have inferior results. Decision making, what choice of procedures can be done, largely it has been debated. We have three group of surgeons with us today. I think over the last couple of hours, we are discussing whether the vertebroplasty is better or a kyphoplasty is better. A couple of surgeons talking, is there any role of cement augmentation? Because in their practice, they feel that the cement augmentation is not really giving the results. But talking about that, there is no clear-cut upper hand of any technique, whether you talk about vertebroplasty, kyphoplasty, or you talk about the latest vesselplasty. But there is a big debate as far as the Indian standards are concerned, that the kyphoplasty is slightly costlier compared to the vertebroplasty. And in Indian setup of vertebroplasty, I would agree with most of the surgeons will have a slight upper hand, mainly because of the cost. When you talk about instrumentation, there are certain osteoporotic principles you need to follow. So for that, you need to understand what are the complications when you deal with instrumentation in osteoporotic spine. So there is broadly being classified into an early complication where there is an LIV, that is the lower instrumented vertebral compression fracture, or there might be an adjacent pedicle or the adjacent vertebral fracture. The late complication can range from pseudoarthrosis to all as latent as thoracic or progressive thoracic kyphosis, or a PJK, which is being described. So this is for sure. We have only one chance, and that might be your last. So whenever you choose your surgery, whenever you choose your instrumentation, it has to be the best on the earth. You cannot rely on the second chance. If I do a MIS right now and think about if it fails, I'll go for a longer segment for the next time. You might not get the second chance. So multi-level fixation, at least 3 levels superior, inferior to the apex, has been described. The use of novel implants is very important. Whenever you do decide on your UI, we don't stop at thoracic kyphosis, because the chances of PJK or a distal or a proximal add-on is very high. As far as possible, augment the UIV, use a soft landing wherever possible. LIV can be as caudal to the lumbosacral kyphosis. If you are going to L5, it's hardly a single level. In osteoporotic spine, in an elderly female or a male, you don't really want a single level, which is a mobile segment. Preferably go to a bigger bone chunks like a sacrum or an ilium if possible. Use multiple points, use hooks, claws, sublaminar wires wherever possible, because sublaminar wires are the ones who are going to take the good part of the bone, the cortical lamina bone. As far as possible, undercorrect the deformity. It has been classically described in all the cases described by Dr. Shailesh Hadgaonkar, that he didn't really went into and did a, try to get as good sagittal parameter as possible. Just stick to the undercorrecting the deformity as far as possible. Fuse in situ wherever you can decrease the strain to the implants. Posterior implants is better. If you are getting good anterior bone contact, fine. If you are not getting anterior bone contact, you can go for anterior reconstruction in those cases. We know that pedicle screw fixation is the implant of choice for most of us. It has been an all-time winner, and that's the only implant which is actually taking a 3-column purchase. So when you use an implant, you need to use implant which is better getting a good purchase out of your weakened bone. You need to use augmentation of the pedicle screw to increase the pull-out strength. So as been described and reiterated by Dr. Hadgaonkar, you need not go to a fancy implant from the start. You might be working or you might be practicing in the remotest of the places where having an expandable screw or a fenestrated screw is probably impossible to have, but you can deal with the own screw, which you can use a maximum length of the screw. You can get a bicortical insertion. Getting a simple bicortical insertion will increase the pull-out strength to as high as 20 to 50%. If you're doing an S1 screw, better to use a bicortical. If you're using a superior end plate or an anteromedial implant, there is a technique described by Lehman et al. Where you really take a tricortical purchase out of the S1 screw. You can afford taking a S1 tricortical screw because anteriorly there are not much structures. If you plan your cases well, if you use something called as neuronavigation, OAM, you can really deal and you can get a good tricortical purchase in S1 screw. Because technically it is slightly demanding when you are planning for a tricortical screw. Have a good triangulations. What is medialization of this? Take the as lateral as possible, the purchase, take good screw coupling, get it as medially as possible, under tap the screw so that you get a bigger size, a pilot hole size screw. When you talk about the screw length, diameter, and the material being used, it has been widely been acceptable that more the length, more the diameter, more it will be the pull-out strength of the screws. And with the novel implants, you can have screws which are peak materials, which can improve the pull-out strength in those screws. They are not very easily available in Indian scenario in most of the remote, prominent setups. But I think Dr. Amit will be favorable to have them in their setup because quite of them are US FDA certified. Cement augmented screws have been utilized quite well by Dr. Basu in his examples. He has used cement augmented screws. You have different varieties of cement augmentation, right from PMMA, so calcium phosphate, which is a bioabsorbable cement. You can resort to a bioactive glass ceramic resins, which is again having a upper hand where because it is a bioabsorbable, you tend to have a good bone ingrowth and bone interdigitation in them. The amount of cement has been debated that at least a cc of screw of the cement should be in the dorsal, whereas 1.5 cc in the lumbar. It definitely increases the pull-out strength, and as high as 190 to 250% of the pull-out strength can be very well increased by a cement augmented screw. You have different percutaneous fixations which has been invoked. I'm not a big proponent of doing a small segment or a shorter segment or a MI screws. In these cases, I would resort to a traditional long segment fixation. But in future, you never know. With good augmentations, good screw hole, you might go to a MIS, and that is probably will be a technique which has to be looked into future. The pull-out strength, when you talk about the cannulated screw versus the cement injected screw, definitely the cannulated cement injected screw has a better hand. Safe surgical technique, when you talk about the cement augmented pedicle screw and the balloon guided kyphoplasty technique, in this, the PMMA augmented screws combined with a balloon assisted kyphoplasty had given a better result with a good pull-out strength. When you talk about the coating, the latest coatings available are the hydroxyapatite coating, which improves the pedicle screw bone contact, bone ingrowth, thereby increasing the mineralization of the bone and in turn increasing the pull-out strength of the bone. The disadvantage is definitely when you tend to remove these implants, especially in infected cases and all, you might land up in trouble. So there are certain novel trajectories being available, the double screws or the cross trajectory screws, where you take the maximum hold into the pedicle and the body, where you can use the traditional screw with something called as cortical bone trajectory screw can be used, can thereby increasing the pull-out strength of the screw. Multiple points as talked. There is a paper, I think Dr. Hadgaonkar himself has a paper where he has revised the pedicle screw with an hard shield rectangle and a sublaminar wires, and his experience has been that the sublaminar wires takes hold of the cortical lamina and thereby increasing the pull-out strength. And if you have multiple points like this with the sublaminar wires and the hooks, you tend to have a better fixation. these are the different three augmentation techniques they have compared, and they have found out that the cement augmentation techniques have a better hold, but also the increasing the point of contact will increase hold of the screws. There are pedicle screw augmentations in osteoporotic spine. The crucial factors, everyone in their own papers have been carefully selected that if you select the patient well, technique selected well, ideal cement augmentation being used, you will tend to have the lesser risk and lesser failures. Expandable screws are available. I don't have a personal experience with this, but it's a good prospect in long term, because since you have a good purchase nowadays, now you get an expandable screw with a cement augmentation, which adds the benefits of both of them. Probably will have a better pull-out strength in the biomechanical studies. Comparing the different screw designs, the PMMA augmented expandable screw had the greatest peak pull-out forces compared to the peak or the expandable pedicle screws. The cortical bone trajectory has seen its rise, its fall, and again, probably with the new techniques and navigations, it is coming back in vogue. You can really use this cortical bone trajectories. There are many papers coming from Japanese side that they're increasingly using this cortical bone trajectories by the bone models they have. The navigation, with the help of the navigation, they can really plan out and have a good cortical bone trajectory screws. The systemic review, which was published in comparing the cortical bone trajectory versus the pedicle screw technique, showed an upper hand of cortical bone trajectory with respect to the pull-out strength, but also to the amount of blood loss was less in CBT. The computer assisted nowadays, these patient-specific trajectory models, which you can put it on the patient's bone, you can use them for the cortical bone trajectory, and you can have the bestest of the whole in the cortical bone. Anterior reconstruction, or do we say that less is more? This is being debated. 360-degree fusion definitely helps in load sharing, but the problems here we are dealing with osteoporotic spine is we don't really get an adequate and a mechanically reliable structure or the struct which can be used for anterior reconstruction. At times, extensive correction will lead to subsidence of strut and ultimately having excessive loading to your posterior pedicles and the pedicle screws. Bony union in osteoporotic fractures is anyway delayed, and with an anterior reconstruction, you might have it more. So the last but not the least is does teriparatide use increases fusion rate? Dr. Nalawane in his talk did stressed on the point that the teriparatide is definitely useful in cases of fusion surgeries, especially in osteoporotic spine. It not only increases the BMD, overall BMD of the bone, but also helps in achieving a faster and an effective fusion, as high as 79% seen in Otori et al. Paper with posterolateral fusion compared to 65% where teriparatide was not given and oral bisphosphonate was given. The role of denosumab is understudied. I think there is definitely a role of denosumab in future studies. If you can compare denosumab with teriparatide and bisphosphonates, you might get an answer to our the lingering problem whether any of this has an upper hand over teriparatide. The duration is not been clear, but most of the endocrinologists, even Dr. Nalawane, said so that at least give for 6 months to a year and don't resort for a shorter duration like 3 months or 3 weeks or 6 weeks. If you want to give teriparatide and if you want to really achieve not only good BMD with fusion, give at least for a year or two, and then you can resort to an alternative anti-osteoporotic agent. So taking a take-home message. So as described by Dr. Zaveri, conservative treatment definitely has a role in Indian setup where the cost of treatment is of these osteoporotic patients and neglected patients might be very high, but there has to be a caveat in this, that regular follow-up of the patient and see who is the collapsing patient or the collapsing spine, who is progressing as far as the kyphosis is concerned, you need to catch up them early and you need to treat them differently. Good selection of the patient, well-performed technique is the bottom line in the overall discussion what we did. Customizing the treatment. You cannot really have a clear algorithm when you talk about treating osteoporotic fracture. You might have to take considerations of the different parameters of the fracture, the fragility indices, the risk stratification of the patient, optimize the patient as a whole and not the osteoporotic spine alone. Long versus short segment fixation is a matter of debate. A good randomized trials in future will definitely give us an answer whether a short segment fixation is better or should we resort to a traditional long segment fixation. There is a plethora of novel techniques which are available. I think using these techniques in reality and using them oftenly will get us good results for sure, because they definitely increases the pull out strength through this or already compromised bone. Just for a food for thought, I think we can discuss this. Can, as we have, we always in fragility indices and the risk stratification, we talk about the heart condition, the lung conditions, the overall well-being of the patient. Can a typical T-score of so and so will lead to a patient can be deemed unfit? Can a T-score, say minus 4.5, make the patient unfit and you cannot operate on this patient and need to optimize before really offering surgery? Or do we, what we do traditionally with taking into consideration multiple factors like age, the health of the patient, the overall health of the patient, the DEXA score, the cross inspection of the bone quality, the indication, are we looking for a magnitude correction of the deformity, the length of the anticipated surgery, the presence or absence of neurological deficit, or the need for anterior surgery? Can we resort to a T-score which can tell us whether the patient is fit or unfit for surgery? Thank you, sir.
Yeah, a superb elaboration, Pramod. Excellent.
Yeah.
Pramod, I want to ask you a few couple of questions. Please allow
yes,
me.
Sir.
I want your say on cobalt chromium versus titanium rods in osteoporosis. Secondly, what about pericortical screws, what you just mentioned? How good are they against the standard screws?
So it's a good question. So thank you for the questions. So one is, I will take the CBD or the pericortical screw first. I had a brief experience of mine when I was in Japan. I think they were in Keio University. They were doing this bone models or the navigation, and through which they were using the CBT. And what I saw, I unfortunately they haven't published yet, but what I saw, their results were really remarkable. They showed a good hold, good pull-out strength in all these CBT screws. Only problem of putting the CBT screws is we as surgeons are not very acquainted with the technique. That slightly technically demanding as far as a newbie is concerned. But if you have opportunity like the neuro navigation, if you have this, you have a navigation and warm, you can really put on this cortical screws or the cortical bone trajectory. There are a couple of papers by Masato et al, and he has actually putting screws through the superior end plate. So you have bicortical one, except the cranial most, but you can put a screw, all the middle screw and especially the lower screws also.
So our 4.5 pedicle screws, can it be an alternative to the CBD screw?
If you can have a cortical bone trajectory, you can. I mean, comparing a cortical bone trajectory with a traditional screw, cortical bone trajectory has an upper hand over the traditional screws.
Okay, the screw design as per se is not different than the pedicle screw.
No, the screw design is not. The trajectory is different.
I think I may differ. Screw is a little different. Screw has the pitch of the threads is little less in cortical.
Yes.
So where I have seen this technique, they were using actually the conical screws, where the pedicle part was the cortical part, and the tip was actually the cancellous part, the conical screws. But I had discussed this with the surgeon who was operating, and he said that they have used the cortical bone trajectory by using the simple Medtronic screws also.
Okay.
Pramod, if I may interrupt.
Yeah.
May interrupt. A few points, about the cost. It depends on how do you calculate the cost. The kyphoplasty, if you calculate the cost of kyphoplasty kit, it's okay. But if you calculate the cost of how much visits the patient is going to have to the hospital, how many investigations the patient is going to do, how many complications she may possibly land up into, how many average wages she's going to lose. If you put that into cost, I think there is nothing as much as cost effective as kyphoplasty.
Yeah.
If you see that. So the estimation of cost, the method of estimation of cost.
Kyphoplasty or vesselloplasty, what do you do?
Kyphoplasty or anything, even vesselloplasty. So if you compare kyphoplasty with vertebroplasty, it's a different issue. But if you say the cost of the procedure is too expensive, I think that statement has to come with a little bit more clear thought, is that it depends how you calculate the cost.
Yeah.
$3,000, for example, 3,000 rupees is the cost for kyphoplasty. I'm just making it up. But I think the amount of pain relief, amount of visits she will be avoiding, amount of complications she will be avoiding in the future life, I think, and the mortality benefit is immense. So I think the cost analysis, I do not completely agree to that statement up there that it's very expensive. Kyphoplasty, also, I think you mentioned few, I think that it's little vague in the literature that superiority of one procedure or the other. There are now level 1 randomized controlled trials available for vesselplasties, for kyphoplasties, for everything. They always state superiority. So they have stated superiority like clearly. So there is something as a registry. If you go by registry, not by individual study, the registry is pretty clear about the positive effects of kyphoplasty over vertebroplasty. I think vertebroplasty is fallen out of favor at this present time because of the increased complication risk that it has, especially if you don't have a high viscosity cement available.
A point well taken, and I think in more time, I would like to thank Dr. Pramod for a wonderful demystifying literature review and all the faculty for giving a great time. I know everyone wanted to talk about their experiences, as this topic is a very burning hot topic for everyone's practice. And you all delegates, also the MOA executives and MOA President Secretary for giving us this wonderful opportunity on a Sunday. Looking forward seeing you. I hope this monsoon gives you a better perspective and have a good time, everyone out there. Thank you all. Thank you.
Shailesh, thank you very much for arranging a very nice faculty and in-depth presentation of all faculties with the clear message.
Thank you.
Thank you, Shailesh. Thank you, Gadegone sir.
Thank you, Shailesh. Thank you all.
Salud.
Chalo, take care. Bye.